Good evening. Welcome to Rest Academy. In this session, you'll get a calm, complete tour of human anatomy essentials. How do simple planes and axes quietly organize the body? Why do tissues and compartments echo the same patterns from head to foot? And how can knowing these structures turn clinical puzzles into clearer answers? During this video, you'll relax while learning a clear, clinically grounded scaffold in one continuous flow. To make this journey complete, I've prepared a free practical guide with a concise summary of tonight's lesson, waiting in the description like a map you can return to whenever needed. Let's begin. You picture a quiet table, a neutral face toward the ceiling, palms open to the sky. This is anatomical position, the standard pose that fixes left and right, front and back, so every description means the same thing at any hour. Without it, words drift. With it, the body becomes a map you can read. Directional terms are your compass. Superior means toward the head, inferior toward the feet, anterior points to the front surface, posterior to the back, medial is closer to the midline that divides you into right and left halves, lateral is farther from it, proximal lies nearer a structure's origin, the shoulder is proximal to the elbow, distal is farther along the limb, the wrist is distal to the elbow, superficial sits closer to the skin, deep lies inward beneath layers. Ipsilateral means on the same side, contralateral on the opposite. These paired words prevent confusion when structures mirror across the midline yet behave differently. Planes turn the body into orderly slices. The sagittal plane divides right and left. A midsagittal slice runs exactly through the midline, while a parasagittal lies beside it. The frontal coronal plane divides anterior from posterior. The transverse axial plane divides superior from inferior. Each plane is not just a drawing convention, motion aligns with them. Flexion and extension mainly occur in the sagittal plane around a mediolateral axis. Abduction and adduction primarily occur in the frontal plane around an antero-posterior axis. Internal and external rotation occur in the transverse plane around a longitudinal axis. When you match motions to planes and axis, anatomy stops being a list and starts behaving like a machine with consistent hinges. Axes run at right angles to planes. The mediolateral axis passes from side to side and permits sagittal plane flexion and extension at joints like the elbow and knee. The antero-posterior axis passes from front to back and permits frontal plane abduction and abduction at the shoulder and hip. The longitudinal axis runs head to toe and permits transverse plane rotation at the shoulder, hip, and spine. If a movement seems ambiguous, imagine the rod, mediolateral, antero-posterior, or longitudinal, around which the part would spin. The plane then announces itself. Cavities supply rooms within the house. The dorsal cavity includes cranial and vertebral spaces that cradle brain and spinal cord. The ventral cavity begins with the thoracic compartment, 2 pleural cavities for lungs, and a central mediastinum for heart, great vessels, trachea, and esophagus. Below the diaphragm, the abdominopelvic cavity is often discussed as abdominal and pelvic regions. Within it, the peritoneal cavity is a potential space bounded by peritoneum, a thin serous membrane that invests organs and lines walls. These membranes, pleura around lungs, pericardium around heart, peritoneum in the abdomen, reduce friction, permit gliding, and create named recesses where fluid or infection may track. Knowing the room and its lining explains where pain localizes and where pathology settles. Surface landmarks pair with planes to guide depth. The midclavicular line, anterior axillary line, and mid-axillary line run vertically over the chest wall. The transpyloric plane, approximately halfway between the suprasternal notch and pubic symphysis, often crosses the pylorus, duodenal bulb, neck of the pancreas, and hilum of kidneys, though individual variation is normal. The umbilicus sits near the L3-L4 level in many adults. The iliac crest peaks near L4, an anchor for estimating lumbar puncture entry levels in a standardized setup. These landmarks are not invitations to perform procedures, they are orientation cues that help you translate a flat image into layers. Variation is the rule, not the exception. An accessory renal artery may supply a lower renal pole. A right hepatic artery may arise from the superior mesenteric artery rather than the common hepatic. The circle of Willis may be incomplete. The palmar arch may be predominantly supplied by the radial artery in one person and by the ulnar artery in another. Muscles like the palmaris longus may be absent. A cervical rib may narrow the thoracic outlet. Variation matters because names assume typical patterns. Your compass words and planes remain steady, but the structures that fill those coordinates can change route. You learn the default, then you expect detours. Communication depends on this shared map. A description such as a 2 centimeter mass deep to the pectoralis major, along the anterior axillary line at the level of the fourth rib in the right hemothorax, instantly conjures a three-dimensional location if you hold the planes and lines in mind. Without that scaffold, listeners picture different places. When teams coordinate around an emergent complaint, say sudden severe chest pressure central and deep, radiating to the left shoulder, precise orientation terms help triage and localize. If you ever experience sudden severe or concerning chest discomfort, shortness of breath, or neurological deficits, seek professional care promptly. Learning maps does not replace medical evaluation when warning symptoms appear. A brief vignette shows why the compass matters. A radiograph is displayed with the left marker visible. The patient's right shoulder is painful after a fall. In anatomical position conventions, the film is viewed as if the patient faces you, so the left marker indicates their left. The distal clavicle projects upward relative to the acromion, a clue to acromioclavicular separation. If the team confuses left and right, imaging and exam no longer match, and care slows while uncertainty grows. The fix is ordinary. Enforce anatomical position, check markers, use planes and lines, speak the same language every time. You can think of this first section as laying graph paper beneath the body. Directional terms are the labeled axes, planes are the grid lines that let you slice cleanly. Cavities are rooms with named walls. Variation is furniture arranged differently inside consistent rooms. Once you carry this mental map, the rest of anatomy will snap to it. Muscles pull in planes, vessels run along predictable corridors, nerves branch with segmental logic. The grid is quiet, steady, and reusable. There is comfort in reliable coordinates. You do not have to memorize a million facts tonight. You only need a compass, a few lines, and the habit of placing every new detail onto that grid. Keep the map. Next, we'll populate it with the living materials that fill each room and glide along each corridor. You place your attention on the body's fabric. 4 tissues weave the whole. Epithelium lines and forms glands. Connective tissue builds scaffolds and fascia. Muscle creates force. Nervous tissue conducts signals. Together they fold into sleeves, pockets, and seams. Then fascia turns those seams into corridors where vessels and nerves travel with minimal friction. Epithelium is a continuous sheet of cells with polarity. An apical surface faces a lumen or the outside world. A basal surface anchors to a thin support layer called the basement membrane. Tight junctions stitch adjacent cells near the apical margin to limit leakage. Adherence junctions and desmosomes bind cells so the sheet can tolerate shear. Gap junctions permit direct communication through tiny channels. When the sheet invaginates, it forms glands. If the gland connects to a surface by a duct, it is exocrine. If the cells lose their duct and release signals into blood, it is endocrine. In the gut, you meet mucosa, a combination of epithelium, a thin supporting lamin, and a delicate layer of smooth muscle, optimized for selective absorption and protection. On the outer surface of organs that glide, the lining is mesothelium, a simple squamous epithelium that secretes a small amount of lubricating fluid. Its quiet polish lets lungs slide in pleura, heart pulse in pericardium, and intestines sway within peritoneum. Connective tissue surrounds and supports everything else. Its cells, fibroblasts, adipocytes, immune cells live within an extracellular matrix. ECM, a blend of collagen fibers for tensile strength, elastic fibers for recoil, and a hydrated ground substance that resists compression. Loose connective tissue places more ground substance between sparse fibers. It occupies spaces where small vessels and nerves branch. Dense connective tissue packs collagen into thick bundles. Tendons align fibers to transmit muscle pull to bone, while ligaments cross joints to restrain motion. Bone and cartilage are specialized connective tissues that you will meet as solid and semi-rigid variations of the same theme. Fascia is connective tissue organized into sheets, sleeves, and septa. Superficial fascia lies just deep to the skin. It blends adipose with delicate fibrous strands, houses cutaneous vessels and nerves, and permits skin to glide over deeper layers. Deep fascia is a firmer, glistening sheet that invests muscles, forms intermuscular septa that attach to bone, and creates osteofascial compartments. Within these compartments, muscles that share function and innervation work efficiently, and neurovascular bundles take protected routes. At joints, fascia thickens into retinacula, transverse bands that restrain tendons so they do not bowstring when you flex a wrist or ankle. Broad tendinous sheets called aponeuroses spread force across wide areas. The palmar aponeuroses stabilizes the hand's soft core as fingers grasp. Muscle tissue occurs in three forms. Skeletal muscle fibers are long, multinucleated cells packed with contractile proteins. Under voluntary control, they produce joint motion and maintain posture. Cardiac muscle cells branch and connect through intercalated discs. Their rhythmic, intrinsic activity pumps blood without conscious oversight. Smooth muscle cells are spindle-shaped and organize into layers in the walls of hollow organs. By contracting in sequences, they regulate vessel caliber and propel luminal contents. Each muscle is wrapped by connective tissue sheaths, endomysium around fibers, perimysium around fascicles, epimysium around the whole muscle. These sheaths merge with deep fascia and tendons, allowing forces to transmit not only along a muscle's length but also laterally into adjacent structures. A reason distant regions can feel tension when one area stiffens. Nervous tissue interlaces with this fabric. Neurons conduct signals, glia support and insulate. Peripheral nerves travel as bundled axons wrapped by endoneurium, grouped into fascicles by perineurium, and enclosed by epineurium. Arteries and veins accompany these bundles in shared connective sleeves. This trio nerve, artery, vein forms a neurovascular bundle that follows fascial planes. The carotid sheath in the neck is a classic example. A dense sleeve gathers the common carotid artery, internal jugular vein, and vagus nerve. Similar sleeves exist throughout the body at smaller scales, guiding predictable pathways that you can trace from surface landmarks to depth. The fabric metaphor becomes literal when you feel sliding. Between fascial layers, a thin film of hyaluronan-rich fluid permits low-friction gliding as muscles lengthen and shorten. When hydration or ECM composition changes, those layers can adhere. Symptoms may localize along lines of pull rather than at a single point. Because deep fascia encloses firm compartments, any rapid increase in volume, bleeding, edema, or reperfusion can raise pressure against contained vessels and nerves. Disproportionate pain, new numbness, or progressive weakness in a limb warrants prompt professional evaluation. The rigid sleeve that aids efficiency can, in rare conditions, endanger perfusion when it cannot stretch. Compartments create order. In the arm, a medial and a lateral intermuscular septum partition flexor and extensor groups, each with its main nerve and artery. In the forearm, a flexor pronator mass lies anteriorly, an extensor supinator mass posteriorly, and a deep fascial plane creates a protected path for the interosseous vessels between radius and ulna. At the wrist, the flexor retinaculum spans a bony arch to form the carpal tunnel, a narrow pass for the median nerve and tendons. Tight spaces explain why even small volume changes can provoke symptoms. In the thigh, a strong lateral septum and the fascia lata divide anterior, medial, and posterior compartments. Vessels dive through name gaps, for example, an adductor hiatus to reach the popliteal fossa. The leg repeats the theme with anterior, lateral superficial, posterior, and deep posterior compartments. Retinacula at the ankle maintain tendon trajectories so the foot's levers work efficiently. Fascial planes help clinicians predict spread. Pus or blood often tracks along the path of least resistance, which is frequently a slick connective tissue interface, rather than through dense muscle. In the neck, spaces between layers of deep cervical fascia can channel infection from the oral cavity to the mediastinum. In the hand, synovial tendon sheaths can communicate between digits and the wrist, explaining why swelling may leap across short distances while sparing intervening skin. In the abdomen, the continuity between mesenteries, folds of peritoneum that convey vessels and nerves, and retroperitoneal connective tissue guides both surgical approaches and patterns of disease. A quiet clinical vignette. A distance runner develops aching in the outer leg that intensifies with time on the trail and eases at rest. Palpation reveals a firm, tender band where the deep fascia blends with the iliotibial tract, a thickened lateral sleeve that stabilizes knee alignment. The pain pattern follows the fabric seam rather than a single joint. Rest, assessment, and targeted evaluation. Clarify whether symptoms reflect overuse within a compartment, a tendon gliding disorder, or another cause. Sudden severe pain, loss of sensation, or foot drop would require timely professional care. Anatomy cannot be solved by endurance when a sleeve becomes too tight. Imaging reflects the same organization. On ultrasound, fascia appears as bright, linear echoes beneath. Muscles show a feathery pattern as fibers reflect sound between connective layers. On magnetic resonance images, deep fascia forms dark, continuous lines. Fluid or inflammation along planes stands out, outlining corridors you already know by touch. During procedures, access often follows these natural seams to reduce trauma. An anterolateral approach to the thigh respects intervals between muscles, while a neck dissection stays within fascial boundaries to protect vessels and nerves. You now hold a mental bolt of cloth rolled from skin to bone, epithelium as the outer and inner lining, connective tissue as warp and weft, muscle as the active threads that shorten, and nerve as the messenger strand that times the pattern. Fascia shapes the garment into sleeves and belts, forms belts into compartments, and turns compartments into predictable streets for vessels and nerves. When you examine a symptom, you ask, which sleeve, which pocket, which corridor? The answers are often found by following seams. A brief thought settles when the layers glide. Effort feels smaller when they stick. Attention is tugged to the line. Learning to picture those lines gives you calm structure for sensation and study. Hold the fabric steady in your mind. Next, rigid elements will arrive. Bone will give these sleeves anchors and levers, and the core column will show how the whole garment holds its shape under load. You feel a quiet framework beneath every breath and step, a central column, a cage that expands, and a protective vault above. This is the axial skeleton, skull, vertebral column, sternum, ribs, and the small suspended hyoid, an architecture that supports, protects, and transmits forces while keeping vital organs safe. Think of a tower with repeated floors and strategic arches. The skull forms the roof and walls of the superior chamber. The vertebral column is the tower's stacked core with interlevel cushions. The sternum and ribs form a flexible ring, the thoracic cage that braces the column and houses the heart and lungs. The hyoid, a U-shaped bone in the neck that does not articulate directly with other bones, hangs by ligaments and muscles to anchor swallowing and speech. Each piece is shaped for its load and neighbor. The vertebral column holds the plan. A typical vertebra has a weight-bearing body in front and an arch behind that surrounds the spinal canal. Projections, spinous, and transverse processes extend as levers for muscles and as struts for ligaments. Between bodies lie intervertebral discs, fibrocartilage pads with an outer ring, annulus fibrosus that resists tension, and a central gel, nucleus pulposus, that distributes compression. Facet joints between arches guide motion. They are synovial joints with capsule and cartilage, and their orientation differs by region to admit or limit certain movements. Ligaments, anterior and posterior longitudinal along the bodies, ligamenta flava between laminae interspinous and supraspinous along the tips, stabilize the stack and store elastic energy during motion. Curvature turns the stack into a spring. Primary curvatures, thoracic and sacral, are concave anteriorly and persist from fetal life. Secondary curvatures, cervical and lumbar, develop with head lifting and upright stance, becoming convex anteriorly. With these alternating arcs, axial loads are not borne straight down. They are dispersed through a gentle S shape, which reduces peak stress and helps the spine balance over the pelvis with minimal muscular effort. When the arcs exaggerate or flatten, force distribution changes, endurance drops, and tissues signal strain. Regional specialization makes the tower practical. Cervical vertebrae are small and permit extensive rotation and flexion. The atlas lacks a body to cradle the skull, and the axis contributes a vertical peg that acts as a pivot. Thoracic vertebrae have facets for ribs. Their long downward slanting spinous processes limit extension and stiffen the cage. Lumbar vertebrae have large bodies for weight and stout processes for leverage. Their facets favor flexion and extension, but restrict rotation. The sacrum fuses into a wedge that transmits trunk weight into the pelvis. Below it, the coccyx anchors the pelvic floor. This shape grammar, small and mobile above, stout and load-bearing below, follows the same mechanical idea along the whole column. The thoracic cage is a flexible ring that breathes and shields. The sternum manubrium, body and xiphoid, forms the anterior bar. The manubriosternal junction, often felt as a ridge, lies at the level where the second ribs attach. This palpable angle helps count ribs and identify internal levels. Ribs 1 to 7 are true, each with its own costal cartilage to the sternum. Ribs 8 to 10 are false, joining the cartilage above. Ribs 11 to 12 are floating, ending in the muscle wall. Posteriorly, each rib links to the vertebral column at costovertebral and costotransverse joints. Small gliding movements at these joints, multiplied across the ring, change chest dimensions quietly with each breath. Breathing reshapes the ring in predictable ways. In upper ribs, the anterior ends rise and fall around a transverse axis, increasing anterior-posterior diameter, often called a pump handle motion. In lower ribs, lateral arcs move around an anteroposterior axis, widening the chest, often called a bucket handle motion. The sternum tilts subtly as the diaphragm descends, and elastic costal cartilages allow recoil. The cage's resilience depends on these joints, cartilages, and the column's flexibility. Stiffness in one element echoes into the others, altering the feel of a full breath. Bone is living connective tissue optimized for its tasks. Cortical bone forms strong outer shells. Trabecular bone forms internal struts aligned along habitual stress lines. In vertebral bodies, trabeculoи sweep from end plate to end plate, resisting compression. At the ribs, curved cortices resist bending. In the sternum, a mix of cortical plates and cancellous core tolerates repetitive microloads. With age, trabecular thickness and connectivity can diminish. The column's capacity to distribute load changes, especially at the thoracic lumbar junction, where transitions concentrate stress. The hyroid small arc is mechanically significant despite its size. Suspended by muscles and ligaments from the mandible, temporal bones, larynx, and pharynx, it serves as a mobile anchor for swallowing and phonation. Its independence from direct bony joints allows fine adjustments without transmitting rigid shocks to the skull base or cervical column, yet its soft tissue ties mean that tone changes in the tongue or suprahyroid muscles can shift laryngeal height and airway space. Surface landmarks anchor this architecture to touch. The external occipital protuberance and the thick ligament that fans from it in the neck anchor posterior cervical muscles. The prominent C7 spinous process marks the cervicothoracic transition. The scapular spine aligns roughly with thoracic levels mid-chest. The inferior angle descends with arm position. The sternal angle guides rib counting. The xiphoid lies over the diaphragm's central tendon. Along the midline of the abdomen, the linea alba runs from xiphoid to pubic symphysis, a tendinous seam that hints at the continuous load path from chest ring to pelvic ring. A clinical vignette grounds the mechanics. A person in their late 60s notices gradual height loss and new mid-back aching that worsens with standing and eases when lying down. Examination reveals an exaggerated thoracic curve with tenderness over a vertebral segment. Vertebral trabecular bone carries much of the compressive load. With lower bone mass, anterior wedge deformities can develop, increasing kyphosis and shifting center of gravity forward. The thoracic cage adapts. Respiratory excursion may feel restricted. Sudden severe back pain after minimal strain, loss of height, new neurological symptoms, fever, or trauma warrant prompt professional evaluation to exclude fracture, infection, or other urgent causes. Architecture teaches patterns, but assessment decides risk. Ligaments explain familiar sensations. The ligamentum flavum, a yellow elastic band, bridges adjacent laminae posteriorly. It recoils during extension and maintains smooth canal walls during flexion. The anterior longitudinal ligament checks extension along vertebral bodies. The posterior longitudinal ligament runs within the canal and checks flexion centrally. In the neck, the supraspinous ligament thickens into the nuchal ligament, a broad midline sheet that supports head posture and provides muscular attachment. When sustained posture loads one arc, these elastic tissues accumulate strain, change the arc, and recoil eases tension, an everyday demonstration of stored elastic energy. Load paths integrate skull, column, and cage. In quiet standing, skull weight descends through the occipital condyles to the atlas and axis, continues through cervical and thoracic bodies, disperses across lordotic and kyphotic arcs, and reaches the lumbosacral junction, where sacral wedge geometry turns vertical load into diagonal forces that the pelvis receives. The thoracic cage shares loads via ribheads and tubercles into the column, while muscles spanning ribs to pelvis modulate tension. This shared architecture explains why changes far from a symptom site, stiff costal cartilages, altered lumbar curvature, or cervical facet irritation can alter how the chest moves or the neck feels during breathing. Reflection settles lightly. When you picture a tower with flexible rings and tuned curves, posture becomes less about rules and more about allowing engineered arcs to carry weight with minimal effort. You now have the tower, the rings, and the roofline in view. Next, you will walk the roof itself, bones, sutures, air-filled spaces, and the perforated cranial base where vessels and nerves pass between brain and body, each opening a deliberate doorway to the world below. You lift your gaze to a quiet vault with purposeful seams and doorways. The skull is a protective shell and a passage hub, 22 bones in adults, joined by fibrous joints called sutures, pierced at the base by openings foramina that let vessels and nerves pass between brain and body. A suture is a fibrous joint where bones meet through a thin layer of connective tissue. It allows growth early in life and later becomes a stable seam. Major sutures include the coronal between frontal and parietals, the sagittal between parietals, the lambdoid between parietals and occipital, and the squamous where temporal meets parietal. In infants, wider membranous areas called fontanelles permit brain and skull expansion. With age, they narrow and ossify. Variations persist in many adults. A midline frontal metopic suture may remain, and small accessory bones, sutural bones, can appear within lambdoid seams without consequence. You trace the roof and walls, the calvaria and lateral faces, then descend to the floor, the cranial base. Inside, 3 depressions, anterior, middle, posterior cranial fasciae, support brain regions and concentrate doorways. The anterior cranial fossa, formed largely by frontal bone, ethmoid and lesser wings of sphenoid, houses the frontal lobes. Its cribriform plate is a perforated ethmoid sheet that transmits olfactory nerve filaments. Trauma here can tear delicate meninges, creating a cerebrospinal fluid leak that presents as clear fluid from the nose. New clear rhinorrhea after head injury, worsening headache, fever, confusion, or neurological changes requires professional evaluation. Structure knowledge guides awareness, not action. The middle cranial fossa, shaped by the greater wings of the sphenoid and the squamous and petrous parts of the temporal bones, supports temporal lobes and shelters key conduits. The sella turcica, a saddle-like depression in sphenoid, cradles the pituitary gland. Anterior to it, the optic canals transmit the optic nerves and ophthalmic arteries into the orbit. Lateral to the sella, the superior orbital fissure opens into the orbit and conveys cranial nerves 3, 4, the ophthalmic division of V1, and CI, along with veins. Posterior lateral to that, the foramen rotundum transmits maxillary division V2, the foramen ovale transmits mandibular division V3, and the foramen spinosum houses the middle meningeal artery. At the skull's thin H-shaped terion, where frontal, parietal, temporal, and sphenoid bones meet, that artery grooves the inner table. A blow here can tear it, leading to an epidural hematoma. Sudden severe headache or neurological deficits after head trauma warrant urgent care. The doorway map explains vulnerability but never replaces assessment. The posterior cranial fossa, the deepest basin formed by occipital bone and the petrous temporal ridges, contains the cerebellum and brainstem. The foramen magnum is the largest opening, allowing the medulla to continue as spinal cord and transmitting vertebral arteries and coverings. Lateral to it, the hypoglossal canals carry cranial nerve 12 to the tongue. More anterior lateral, the internal acoustic meatus conveys facial phevan and vestibulocochlear fate nerves into the petrous temporal bone. The facial nerve then enters a narrow canal, gives off branches within the bone, and exits the skull via the stylomastoid foramen to innervate muscles of facial expression. The vestibulocochlear nerve divides into vestibular and cochlear parts for balance and hearing. Posterior lateral, the jugular foramen transmits cranial nerves 9s, X, Li, and drains venous blood from the sigmoid sinus into the internal jugular vein. Hoarseness, dysphagia, shoulder droop, or tongue deviation after base of skull injury points to these exits. Pattern recognition ties symptom to doorway. Between middle and posterior fossae lies the cavernous sinus, a venous channel along either side of the sella that contains the internal carotid artery and cranial nerves 3, 4, V1, V2, and CI. within or in its lateral wall. Because facial and ophthalmic veins communicate with this sinus, infections in the central face can, rarely, spread inward. Fever, severe headache, eye movement problems, or new swelling around one eye deserve prompt evaluation. The danger is anatomical. Emissary pathways lack valves, so flow can reverse under pressure changes. The outer base shows linked arches and buttresses. The zygomatic arch formed by zygomatic and temporal bones is a lateral strut for chewing muscles. The maxillae form the anterior hard palate. Posteriorly, the palatine bones complete the roof of the mouth and floor of the nasal cavity. Posterior to the palate, the pterygoid plates of the sphenoid descend as thin bony laminae. Between them, muscles of mastication attach, and a case-like space, the pterygopalatine fossa, houses a dense neurovascular network that supplies the nasal cavity, palate, and orbit through small canals and fissures. The temporomandibular joint, TMJ, is a synovial joint with a fibrocartilaginous disc between the mandibular condyle and the mandibular fossa of the temporal bone. It combines hinge rotation and translation gliding so that you can open widely by first rotating, then gliding the condyle forward onto the articular eminence. Because the articular surfaces are fibrocartilage rather than hyaline cartilage, they tolerate repetitive shear. The disc divides the joint into two cavities, each with its own motion. Clicking, locking, or new malocclusion after trauma suggests mechanical disturbance. Persistent pain or jaw limitation warrants examination to clarify whether soft tissue, disc, or muscular causes predominate. Air-filled paranasal sinuses lighten the skull and condition-inspired air. Frontal sinuses sit within the frontal bone. Maxillary sinuses occupy maxillae beneath the orbits. Ethmoidal air cells form a honeycomb between nasal cavity and orbit. Sphenoidal sinuses lie in the sphenoid body behind the nasal cavity and below the sella. Each drains through small ostia into the nasal meatus. The osteomedal complex in the lateral nasal wall coordinates much of this drainage. Thin orbital walls, especially the ethmoid's lamina papyracea, can fracture inward with blunt force, allowing orbital contents to herniate into the ethmoid or maxillary sinus. Numbness of the cheek indicates infraorbital nerve involvement. You do not diagnose by feel here. You learn the walls so images and symptoms align in your mind. The orbit is a pyramidal cavity with a base at the face and an apex posteriorly. Its 7 bony contributors, frontal, zygomatic, maxilla, ethmoid, sphenoid, lacrimal, and palatine, create thin partitions around a critical corridor. The optic canal at the apex transmits the optic nerve. The superior orbital fissure lies between greater and lesser wings of sphenoid. The inferior orbital fissure communicates with the pterygopalatine and infratemporal fossae. Understanding these roots explains how symptoms cluster. Double vision with restricted gaze implicates the nerve-rich superior fissure. Visual loss points to the optic canal. Cheek paresthesia implicates the infraorbital canal along the orbital floor. The temporal bone's petrous part is a dense pyramid-like wedge that houses the middle and inner ear. The middle ear is an air-filled space with 3 ossicles, malleus, incus, stapes, that transmit vibrations from the tympanic membrane to the inner ear. It communicates with the nasopharynx via the pharyngotympanic auditory tube, which helps equalize pressure. The mastoid portion contains air cells that open into the middle ear. Infection can track through these cells into bone. New fever with ear pain, post-auricular tenderness, or swelling warrants assessment. The bone's dense geometry hides vulnerable air pathways until you picture them. Scalp and skull layers add a protective envelope. The scalp's 5-layer concept is a memory aid. Skin, connective tissue, dense, vascular, aponeurosis, a strong tendinous sheet connecting frontalis and occipitalis, loose areolar tissue that permits the first 3 layers to glide, and pericranium periosteum over bone. Emissary veins traverse the skull to connect scalp veins with dural venous sinuses. While they aid temperature regulation and pressure equalization, they also offer potential routes for infection. Beneath the inner table, a spongy layer of bone called diploe cushions, impacts, and houses venous channels. You can read the skull like a house plan. Sutures are seams, fossae are rooms, foramina are doors, canals are hallways, sinuses are carefully placed voids that lighten without weakening. Patterns repeat. Nerves pass through narrow bony tunnels and split to supply regions with predictable sensory maps. Arteries groove inner surfaces and then branch across territories. Variation adjusts dimensions but preserves adjacency. Optic canal still meets orbit. Jugular foramen still opens to the neck. Foramen magnum still anchors the central passage. A brief vignette ties map to moment. After a minor fall, a patient develops a worsening, localized temporal headache and brief loss of awareness, then rallies and feels okay. Hours later, drowsiness and weakness emerge. At the pterion, bone is thin and overlies the middle meningeal artery. A tear here can bleed between bone and dura, forming a lens-shaped collection that compresses nearby brain tissue. The anatomical relationships explain why an initially lucid period can precede deterioration. Any new severe headache, head injury with neurological change, or clear fluid from nose or ear warrants prompt professional care. Quietly, a thought. Seeing the base as orderly doors and corridors replaces fear with a map. You do not rush toward certainty. You label the room, the seam, the door, and let the pattern guide understanding. Through the largest doorway, the foramen magnum, the brainstem continues as the spinal cord and exits into a column of repeating arches. Now you will follow that cord through vertebral levels, discs, and roots to learn why limb pain traces specific stripes. You step into a long lighted highway that runs from skull base to sacrum. This is the vertebral canal, a protective tunnel built by stacked arches. Inside runs the spinal cord, a thick main road of axons. At each level, paired exit ramps, nerve roots, peel off through intervertebral foramina, the bony gateways shaped by adjacent vertebrae, and the intervening disc. A vertebra contributes to the tunnel with a posterior arch and to load bearing with its anterior body. Between bodies, an intervertebral disc cushions and binds. The disc has an annulus fibrosus, a concentric fibrous ring that resists tension, and a nucleus pulposus, a hydrated core that distributes compressive load. Because the posterior longitudinal ligament is narrower than the anterior one, the weakest path for a pressurized nucleus lies posterior lateral. That path points toward the lateral recess where a descending nerve root travels, explaining common patterns of disc-related symptoms. Within the canal, the spinal cord is wrapped by three meninges: dura mater, a tough outer sleeve; arachnoid mater, a delicate intermediate layer; and pia mater, a thin inner coat that follows every contour. Between dura and vertebral canal lies the epidural space, containing fat and a venous plexus. Between arachnoid and pia is the subarachnoid space, filled with cerebrospinal fluid that cushions the cord. Inferiorly, the cord tapers to the conus medullaris and continues as a thin pia strand, the filum terminale, anchored to the coccyx. Below the conus, lumbar and sacral roots travel together in the canal before exiting. This bundle is the cauda equina, a spray of cables waiting for their ramps. Roots are half-formed nerves. Each spinal segment produces a ventral anterior root carrying motor fibers away from the spinal cord, and a dorsal posterior root carrying sensory fibers toward the spinal cord. The dorsal root bulges at the dorsal root ganglion, a knot of sensory neuron cell bodies. Immediately beyond, dorsal and ventral roots unite to form a mixed spinal nerve, which then divides into dorsal and ventral rami to supply back and front territories respectively. A dermatome is the skin territory supplied by a single spinal level. A myotome is the set of muscles primarily powered by that level. You do not have to memorize all of them. You trace the logic. Neighboring dermatomes form stripes. Myotomes cluster in functional arcs like elbow extension or ankle plantar flexion. Numbering clarifies ramps. In the cervical region, nerves C1, C7 exit above their correspondingly numbered vertebrae. C8 exits between C7 and T1. Below that, thoracic and lumbar nerves exit below their vertebrae. T5 exits below T5, and so on. A posterolateral disc bulge usually impinges the root that is descending to exit at the level below. At C5, C6, the C6 root is more vulnerable. At L4, L5, the L5 root is more vulnerable. At the far lateral margin, where the nerve has already reached the foramen, the exiting level can be affected. The map is consistent once you match the ramp to the disc's edge. The highway metaphor guides symptoms. Radicular pain, pain that travels along a nerve root's distribution, follows a stripe, and may be sharp, electric, or burning. In the cervical region, C6 root irritation often produces pain and paresthesia into the lateral forearm and thumb with biceps reflex change. C7 involvement can weaken triceps and wrist extensors and alter sensation at the middle finger with a triceps reflex change. C8 relates to the ring and little fingers and intrinsic hand muscles. In the lumbar region, L5 root involvement often creates dorsal foot and great toe symptoms with ankle dorsiflexion weakness. S1 often produces lateral foot symptoms with plantar flexion weakness and an Achilles reflex change. These are tendencies, not guarantees. Individual variation and mixed processes can blur the pattern. Synostosis narrows the tunnel. Central canal narrowing, often from disc bulge. Facet joint osteophytes and thickened ligamentum flavum can compress multiple roots as they travel in the cauda equina. Symptoms may include leg heaviness or pain with walking that eases when you flex the spine slightly, opening the canal's diameter. Foraminal stenosis, in contrast, narrows the exit ramp where a single root crosses the doorway. The pattern becomes more focal. Fever, unexplained weight loss, night pain that does not ease, new bowel or bladder dysfunction, saddle area numbness or rapidly progressive weakness merits prompt professional evaluation. Some signals point to more than ordinary highway crowding. Blood supply organizes like feeder roads. The anterior spinal artery runs along the ventral surface of the cord, supplying anterior 2/3 of the cord motor tracts and pain temperature pathways, while paired posterior spinal arteries feed the dorsal columns, position and vibration pathways. Segmental medullary arteries join from the body wall, one large contributor, often arising on the left between lower thoracic and upper lumbar levels, strengthens lumbar flow. Because perfusion arrives segmentally, watershed zones exist. Sudden loss of anterior flow can produce bilateral motor weakness with preserved position sense. You do not diagnose by map alone, you learn why patterns differ. Ligaments and joints shape the roadway. Facet, zygapophyseal joints guide motion and, with discs, share load. Their capsules can hypertrophy with chronic stress and encroach on foramina. The ligamentum flavum, elastic and spring-like, can thicken and buckle inward with extension, reducing canal diameter. The posterior longitudinal ligament within the canal limits flexion. Its lateral weakness invites posterolateral disc migration. Spondylolisthesis, an anterior shift of one vertebra on another, narrows foramina and central canal. The ramp tightens when the deck slides. These elements explain why certain postures soothe and others aggravate. A quiet vignette roots symptoms to structure. A person in their 40s develops neck pain after a day of overhead work, followed by tingling down the posterior arm to the middle finger, and difficulty pushing open doors. On examination, elbow extension is weaker, and the triceps reflex is diminished. The hallway logic points to the C7 root, an exit ramp narrowed by a combination of uncurvaturable osteophytes and a C6-C7 disc bulge. Over days to weeks, progressive weakness, worsening numbness, or gait disturbance would warrant timely professional care. Sudden severe neck trauma, fever, or new bowel bladder change requires urgent evaluation. The same framework distinguishes low back radicular stripes from hip or sacroiliac sources that refer pain without neurologic findings. The cauda equina's long floating cables create a different risk. Because lumbar and sacral roots travel together below the conus, a large central L4, L5, or L5-S1 disc extrusion can compress multiple roots at once. New urinary retention or incontinence, numbness around the inner thighs or perineum, or bilateral leg weakness demands immediate assessment. The highway image clarifies why. A central blockage below the mainline taper sits across many ramps at the same time. Imaging translates anatomy to pictures. On sagittal MRI, vertebral bodies stack with dark end plates. Discs appear as darker cushions with brighter water content centrally in youth. Posterior lateral protrusions indent the thecal sac. Severe foraminal narrowing pinches the fat signal around an exiting root in the coronal plane. CT outlines osteophytes and bony narrowing with high contrast. Yet the map remains primary. Images often reveal age-consistent changes in people without symptoms. Pattern matching of story, examination, and images yields clarity. Reflection stays brief. A long road with timed exits feels less daunting than a tangle of wires. Once you know where the ramps are, you can name the lane where a signal flickers. Your highway rejoins the ring of ribs and the muscular floor that reshapes each breath. Next, you will watch the thoracic cage and diaphragm turn this column into a bellows that moves air with quiet precision. You notice the hush between inhalations, the chest expands, the abdomen softens forward, and air slides in without strain. A rigid cage should not move like this, yet your thoracic cage, sternum, ribs, and thoracic vertebrae flexes subtly while guarding heart and lungs. The secret is in its joints, cartilages, and a muscular floor called the diaphragm. The thoracic cage is a ringed framework that protects viscera and supports breathing. Anteriorly stands the sternum, manubrium, body, and xiphoid, joined by synchondrosis and a palpable ridge at the manubriosternal junction that aligns with the second ribs. Laterally arc 12 pairs of ribs. Typical ribs 3 to 9 have a head with facets for 2 adjacent vertebral bodies, a neck, a tubercle for the transverse process, and a shaft with a costal groove. Atypical ribs depart from this pattern. The first rib is short and broad, curving deeply under the clavicle. Ribs 11 and 12 lack anterior cartilaginous connections. Costal cartilages prolong ribs to the sternum, ribs 1-7, or to the cartilage above, ribs 8-10, while ribs 11 and 12 end in the abdominal wall. Posteriorly, costovertebral and costotransverse joints create small glides that multiplied across the ring, reshape chest dimensions with each breath. Intercostal spaces are the intervals between ribs, numbered by the rib above. Within each space runs a neurovascular bundle, vein, artery, nerve, from superior to inferior, tucked beneath the rib in the costal groove, with smaller collateral branches near the superior edge of the rib below. The intercostal nerve is the ventral ramus of a thoracic spinal nerve. It supplies the intercostal muscles, parietal pleura, and a band of skin along the chest and abdomen. Because bundles shelter beneath ribs, procedures often consider their course. Here you only need the picture, a protected trench under a curved beam. 3 layered muscles span the spaces. External intercostals run in foromedial, hands in pockets direction, and elevate ribs, enlarging the chest in quiet and deeper inspiration. Internal intercostals run inferolaterally, and their interosseous portions depress ribs to aid expiration, while interchondral portions can help elevate anterior rib ends. Innermost intercostals mirror the internal layer more deeply, and along with thin transversus thoracis on the inner anterior chest wall and subcostal slips posteriorly, reinforce the wall and guide vessels. Because these fibers cross obliquely, they resist deformation and distribute force, much like woven straps binding a collapsible frame. The diaphragm is a dome-shaped muscle that partitions thorax and abdomen. Its muscular fibers arise from the sternum, costal margin, and lumbar crura, and converge on a central tendon that fuses to the fibrous pericardium. When the diaphragm contracts, the domes descend, increasing the vertical dimension of the thoracic cavity and lowering intrathoracic pressure. Air flows inward as the abdomen's contents shift anteriorly. When it relaxes, elastic recoil of lungs and chest wall and gentle abdominal pressure push domes upward. The diaphragm also contributes to venous return by altering pressure gradients and to abdominal functions that benefit from increased intra-abdominal pressure, such as defecation and parturition. These are coordinated reflexes rather than tasks you consciously perform. Openings through the diaphragm permit continuity between regions. A caval opening in the tendon allows the inferior vena cava to pass and dilates during inspiration, favoring venous return. An esophageal hiatus within the right crus permits the esophagus and vagal trunks to traverse. Its muscular sling can help prevent reflux during increased abdominal pressure. An aortic hiatus posterior to the median arcuate ligament allows the aorta and thoracic duct to pass because it lies behind the diaphragm's contractile fibers. Blood flow in the aorta is not compressed by diaphragmatic motion. These routes are fixed corridors. Their positions explain how symptoms can reflect pressure changes or herniation of abdominal contents into the chest when supports fail. Breathing mechanics combine joint geometry and muscle timing. Upper ribs move primarily with a pump handle motion. Their anterior ends rise and the sternum lifts slightly, increasing the anteroposterior diameter of the chest. Lower ribs swing laterally in a bucket handle motion, increasing transverse diameter. The costal cartilage's elasticity allows these arcs. Aging stiffens them, reducing range. The diaphragm adds vertical expansion. Together, these three dimensions change thoracic volume and pressure seamlessly. During quiet breathing, the diaphragm leads while external intercostals stabilize spaces and prevent inward collapse. During deeper breaths, scalenes elevate the first two ribs and sternocleidomastoids can assist. During forceful expiration, abdominal muscles depress the ribcage and push domes upward, while internal intercostals interosseous fibers guide descent. Pleura turn movement into low friction glide. Parietal pleura lines the chest wall, diaphragm and mediastinum. Visceral pleura invests the lungs. Between them spreads a thin film of fluid in a potential space that allows sliding while maintaining adhesion via surface tension. As the diaphragm descends, pleural pressure drops, lungs expand to follow the chest's motion. Recesses, cost, diaphragmatic and costomediastinal are pleural reflections where the lungs do not fully occupy the pleural cavity. During quiet breathing, fluid gravitates to these dependent spaces. Pain from parietal pleura is sharp and localizes to the chest wall, dermatomes of the supplying intercostal nerves, or to the shoulder via the phrenic nerve. When diaphragmatic pleura is involved, the visceral pleura lacks the same somatic pain sensitivity. Vessels trace predictable paths. The internal thoracic arteries descend along the inner chest wall, just lateral to the sternum, sending anterior intercostal branches to meet posterior intercostal arteries that arise from the thoracic aorta. This paired supply creates an arcade in each space, with accompanying veins draining to internal thoracic veins and the Axial System. Knowledge of these arcs explains why certain incisions follow or avoid particular lines, and why collateral circulation can maintain flow when one route narrows. A quiet vignette couples map to sensation. After a fall on the side, a person develops focal pain along the mid-axillary line that sharpens with deep breaths and coughs. Palpation reveals tenderness over the angle of a rib. The intercostal nerve's cutaneous branch supplies a band of skin at that level. Parietal pleura shares the same segmental innervation. Pain increases with respiratory motion because costovertebral joints and intercostal muscles must move with each breath. Splinting the chest reduces motion but can risk shallow breathing. Severe chest pain with shortness of breath, fever, cough with blood, or new asymmetry of chest expansion warrants prompt professional evaluation. Sharp pain alone is not a diagnosis, only a sign routed by anatomy. Thoracic inlets and outlets define transitions. The superior aperture admits trachea, esophagus, vessels, and nerves between neck and chest. The inferior aperture is closed by the diaphragm, which transforms abdominal pressure changes into thoracic pressure changes, and vice versa. Near the superior aperture, the first rib, clavicle, and scalene muscles frame narrow spaces where neurovascular bundles pass to the upper limb. Posture or anatomical variations can alter dimensions here, producing symptoms that mimic distal disorders. You will meet these corridors again when the shoulder girdle arrives and drapes over the cage. The wall and floor cooperate beyond breathing. Each cough or laugh recruits diaphragm, intercostals, and abdominal wall in timed sequences. Each step transmits ground reaction forces through ribs and vertebral joints, while the diaphragm manages pressure and the heart glides within its pericardial cradle on the central tendon. Because motions are small and constant, efficiency rests on healthy sliding interfaces: pleura for lungs, fascia for muscles, synovial membranes for small rib joints. When one interface stiffens, adjacent systems borrow range. A tight chest wall may make the neck work harder to lift the upper ribs. A short reflection, noticing breath as a three-dimensional change forward, sideways, downward, replaces effort with curiosity. The cage was built to move just enough, often and quietly. The shoulder ring now comes into view, a floating girdle that rests on this breathing cage, suspended by muscles, stabilized by a single bony joint in front, and guided by tendons that steer the humeral head. How does such freedom avoid instability? You picture a suspension bridge anchored to the chest. One slender strut. The clavicle spans from sternum to scapula. Behind it, a flat platform. The scapula floats on the rib cage. From that platform, a rounded column. The humeral head articulates with a shallow socket. Cables and bearings keep the span light, yet stable. This is the shoulder girdle and shoulder joint. The clavicle is S-shaped and subcutaneous along its length. Medially, it meets the manubrium at the sternoclavicular SC joint. the upper limb's only true bony link to the axial skeleton. The SC joint is a saddle-type synovial joint with an articular disc that divides it into two cavities, strong ligaments, anterior and posterior sternoclavicular, interclavicular bridging the top of the manubrium, and costoclavicular tethering to the first rib, permit elevations, depression, protraction, retraction, and axial rotation. Laterally, the clavicle meets the acromion at the acromioclavicular AC joint, a planar synovial articulation that allows small glides. Its capsule is modest. Real suspension comes from the coracoclavicular ligament, a two-part cable trapezoid laterally, conoid medially, that hangs the scapula from the clavicle and converts vertical loads into clavicular compression. The scapula is a triangular plate that rides on the thoracic wall. A prominent spine divides its posterior surface into supraspinous and infraspinous fasciae. The acromion extends laterally to meet the clavicle. The coracoid process hooks forward as an anterior lever for muscles and ligaments. On the lateral angle lies the glenoid fossa, a shallow pear-shaped socket that faces anterolaterally. A fibrocartilaginous rim, the glenoid labrum, deepens the socket and improves congruence. The subscapular fossa on the anterior surface glides over the ribs on a bed of muscle and bursae. The scapulothoracic joint, a functional articulation rather than a true capsule-lined joint. The glenohumeral GH joint is a ball and socket with unmatched range. The capsule attaches around the glenoid and along the anatomical neck of the humerus. Its inferior portion forms a redundant axillary pouch that unfolds in abduction. Thickened bands, the superior, middle, and inferior glenohumeral ligaments, reinforce the anterior capsule. The inferior complex, especially its anterior band, resists antero-inferior translation when the arm is abducted and externally rotated. The coracohumeral ligament spans from coracoid to humeral head, blending with the capsule superiorly. The tendon of the long head of the biceps originates from the supraglenoid tubercle and superior labrum, passes within the joint cavity, then exits through the bicipital groove. A transverse humeral band keeps it in the groove as it descends. A coordinated rhythm links bridge and platform. When you elevate the arm in the scapular plane, approximately 2 degrees of GH motion pair with 1 degree of scapulothoracic upward rotation after the first early arc. The AC and SC joints share this scapular rotation and posterior tilt. Upward rotation comes from a force couple between serratus anterior, drawing the inferior angle forward and laterally, and trapezius, upper fibers elevating the lateral clavicle and acromion, lower fibers depressing the medial spine, while rhomboids and levators stabilize. Humeral external rotation during elevation clears the greater tubercle from the coracoacromial arch, preserving a narrow subacromial corridor. Rotator cuff tendons act like precision bearings at the ball and socket. 4 muscles, supraspinatus, infraspinatus, teres minor, and subscapularis, arise from the scapula, fuse with the capsule, and insert on the greater and lesser tubercles. Their coordinated contraction compresses the humeral head into the glenoid. Concavity compression and steers it. As the deltoid drives elevation with an upward shear, the cuff counters by drawing the head medially and inferiorly, maintaining centering. Supraspinatus contributes the first degrees of abduction and continues through the range. Infraspinatus and teres minor externally rotate. Subscapularis internally rotates and provides anterior restraint. A large bursa, the subacromial subdeltoid bursa, lies between cuff and coracoramal arch to promote smooth glide. Crowding of this interval produces familiar, activity-linked pain. The coracoacromial arch forms a roof, acromion, AC joint, and coracoacromial ligament. Beneath it pass the supraspinatus tendon, long head of biceps tendon, and bursa. Shape variations of the acromion and AC joint, thickening of coracoacromial tissue, or superior migration of the humeral head can narrow the arch. Repetitive overhead motion can inflame the bursa and strain the cuff fibers. Because the cuff blends with the capsule, degenerative tears can destabilize steering and shift load to neighboring tissues. Neurovascular routes thread the bridge's pylons. The axillary nerve C5-C6, a branch of the posterior cord of the brachial plexus, passes through the quadrangular space bounded by teres minor, superior, teres major inferior, long head of triceps medial, and the surgical neck of the humerus lateral, along with the posterior circumflex humeral artery. It winds around the surgical neck to supply deltoid and teres minor and a patch of skin over the lateral shoulder. The suprascapular nerve C5-C6 arises from the upper trunk, travels under the superior transverse scapular ligament through the suprascapular notch to supraspinatus, then around the spine through the spinoglenoid notch to infraspinatus. Its companion artery usually passes over the ligament, a dependable relationship at the notch. The long thoracic nerve C5-C7 runs on the chest wall superficial to the serratus anterior. Injury weakens scapular protraction and upward rotation, producing medial border winging with push motions. Dorsal scapular nerve to rhomboids and levator scapulae. Spinal accessory nerve to trapezius and thoracodorsal nerve to latissimus dorsi complete the key scaffolding. Arterial loops create a resilient supply. The axillary artery, a continuation of the subclavian, gives branches that serve the girdle and joint, superior thoracic, thoracoamial, lateral thoracic, then from its third part subscapular, dividing into thoracodorsal and circumflex scapular, and anterior and posterior circumflex humeral arteries that circle the surgical neck. Around the scapular, an anastomotic network between the dorsal scapular or deep branch of transverse cervical, suprascapular, and circumflex scapular arteries permits collateral flow if one route narrows. These loops travel within fascial planes. Inflamed or constricted tunnels can trap companions. Artery and nerve symptoms sometimes coexist. Clinical patterns follow structure. A fall onto the shoulder can separate the AC joint, mild sprain with intact coracoclavicular cables, or higher grade injury with torn trapezoid and conoid, letting the scapula drop and the clavicle appear prominent. A fall on the outstretched hand often fractures the clavicle midshaft. The medial fragment elevates under sternocleidomastoid pull, while the lateral fragment and limb droop. Because subclavian vessels and the lung apex lie deep to the medial clavicle and first rib, high-energy injuries with swelling, deformity, shortness of breath, or neurological change demand prompt evaluation. Glenohumeral dislocation is commonly anterior, often with the arm abducted and externally rotated. The humeral head escapes anteroinferiorly, potentially injuring the axillary nerve. Numbness over the lateral shoulder or deltoid weakness suggest involvement. Bony and labral injuries cluster, a posterolateral humeral head impaction, Hill Sachs, and an anteroinferior labral detachment, Bankart, reflect the direction of escape. Posterior dislocations are less common but occur with seizures or electric injury. Limited external rotation alerts you to the alternative pattern. Sudden loss of the ability to raise the arm, visible deformity, fever, or new neurological deficits are reasons to seek professional care promptly. Rotator cuff disorders are frequent. Degenerative tearing often begins in supraspinatus where tendon fibers curve under the arch. Pain can localize to the lateral shoulder and worsen with mid-range abduction, sometimes easing at extremes. Weakness and resisted external rotation suggests infraspinatus involvement. Weakness in belly press or liftoff tests implicates subscapularis. In subacromial bursitis, passive motion may be less painful than active elevation because the bearing bursa, rather than the driver cuff, is inflamed. Adhesive capsulitis thickens the capsule and obliterates the axillary pouch. Both active and passive motion become globally restricted. The map distinguishes steering failure from space narrowing and capsular constraint. Entrapment syndromes reflect the bridge's tunnels. The suprascapular notch can narrow under a thickened ligament or cyst from the glenoid labrum, weakening abduction initiation and external rotation. At the spinoglenoid notch, isolated infraspinatus weakness appears. The quadrangular space can be compressed. Throwers sometimes report posterior shoulder pain and deltoid fatigue. Imaging may reveal focal denervation. Long thoracic nerve vulnerability to traction produces scapular winging that magnifies subacromial crowding because upward rotation falters. The arch narrows when the platform cannot tilt. Imaging echoes anatomy. On radiographs, the AP and axillary views reveal alignment, fractures, and joint spaces. Outlet and Zonka views profile the acromion and AC joint. Ultrasound depicts dynamic tendon glide beneath the arch and identifies bursal fluid. MRI shows cuff integrity, labrum, and the caliber of the subacromial space. CT clarifies fracture geometry, yet the suspension image remains primary: strut, platform, cables, bearings, and the ball that must stay centered as large arcs unfold. A brief vignette ties the themes. An overhead painter develops aching with mid-range elevation and night discomfort lying on the affected side. Examination shows painful arc from about shoulder height to above, mild weakness in resisted external rotation, and scapular dyskinesis with early shrug. The suspension bridge tells you where to look. The subacromial bearing and the steering tendons plus the platform's upward rotation. New traumatic onset with inability to lift, swelling, fever, or numbness requires timely professional assessment. A map organizes concern without guessing at cause. A quiet thought closes. When you picture a light bridge held by tuned cables and guided by precise bearings, your shoulder's freedom feels coherent rather than precarious. Follow the cables distally now. The bundles in the axilla divide into named nerves that supply forearm and hand. Within tight fascial corridors, how do three main nerves govern strength, precision, and sensation across so many compartments? You follow a wiring harness that splits neatly at the axilla and dives into conduits along the arm, forearm, and hand. Each sheath muscle compartment or osteofibrous tunnel routes one of three main cables, median, radial, and ulnar nerves. Around them, paired arteries and veins form loops that keep current flowing even when a line narrows. The harness powers strength, precision, and sensation with predictable branching. The arm brachium has two osteofascial compartments. Anterior contains elbow flexors, biceps brachii, brachialis, and coracobrachialis, innervated by the musculocutaneous nerve, which then becomes the lateral cutaneous nerve of the forearm. Posterior contains elbow extensor triceps supplied by the radial nerve. The brachial artery descends in the medial groove with median nerve, giving profunda brachii, deep artery of arm, that follows radial nerve into the posterior compartment through the triangular interval bounded by teres major, the humerus, and the long head of triceps. At the elbow, collateral and recurrent branches create an anastomotic ring around the joint. The arterial detour protects perfusion during flexion and compression. The radial nerve leaves the posterior cord, winds in the spiral groove on the humerus, pierces the lateral intramuscular septum, and divides near the elbow. Superficial radial is purely sensory to dorsolateral hand skin. Deep radial passes through the supinator between its heads at the arcade of Frost to become the posterior interosseous nerve, PN, which powers wrist and finger extensors and supinator. Compression in this fibrous arcade weakens extension without sensory loss. The motor-only branch explains the silent skin. The median nerve travels with the brachial artery, crosses the elbow anteriorly deep to the bicipital aponeurosis, and enters the forearm between pronator teres heads. Before the wrist, its anterior interosseous branch dives along the interosseous membrane to power deep flexors, flexor polypicil longus, lateral half of flexor digitorum profundus, and pronator quadratus. This branch is motor only, so pain and weakness in pinch, thumb to index, occur without numbness. The main median trunk continues to the wrist, passes under the flexor retinaculum within the carpal tunnel, and supplies the narrow precision. The ulnar nerve runs medial in the arm, passes posterior to the medial epicondyle in the cubital tunnel, a fibro-osseous groove with an aponeurotic Osborn's ligament roof, and then travels between flexor carpi ulnaris heads. It innervates FCU and the medial half of FDP. At the wrist it courses superficial to the flexor retinaculum, but through its own canal, Guyon's canal, bounded by pisiform hook of Hammett and a roof of ligament and fascia. There it splits into deep motor dominant and superficial sensory branches, commanding most intrinsic hand muscles. The forearm is a paired conduit with an interosseous membrane between radius and ulna. This fibrous sheet transmits load from the radius, which takes most wrist force, to the ulna and stabilizes pronation, supination, the rotational motions around a longitudinal axis at the proximal and distal radio-ulnar joints. Proximal, the radial head spins against capitulum and radial notch, while the annular ligament forms a ring. Distal, the ulnar head rotates within the sigmoid notch of the radius, while the triangular fibrocartilage complex, TFCC, stabilizes the ulnar side of the wrist. You turn a doorknob because these rings and membrane share torque reliably. Anterior forearm flexor pronator mass has 3 layers: superficial from medial epicondyle, pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris; intermediate, Flexor digitorum superficialis, whose tendons split at the proximal phalanx to let profundus pass. Deep flexor digitorum profundus, flexor pollicus longus, pronator quadratus. Innervation is mainly median. FCU and the ulnar half of FDP are ulnar. Posterior forearm extensor supinator mass includes wrist extensors ECRL, ECRB, ECU, finger extensors EDC, EDM, EI, thumb extensors and abductor EPL, EPB, APL, and supinator. Pin supplies most. Their tendons cross the wrist beneath the extensor retinaculum in 6 synovial-lined compartments. Swelling or synovial thickening within a tight compartment alters glide and friction. At the wrist, 8 carpal bones form 2 rows that arch to create a concavity. The flexor retinaculum, transverse carpal ligament, spans this arch to form the carpal tunnel. Within lie 9 flexor tendons, FDS pix 4, FDP pix 4, FPL pix 1, and the median nerve. Because the tunnel is inelastic, small volume increases, synovial swelling, fluid shifts, raise pressure, and selectively affect the median nerve. Numbness in the lateral 3.5 digits, nocturnal paresthesia, and then fatigue. Proximal median nerve irritation at pronator teres can mimic symptoms but tends to spare nocturnal worsening and affects forearm pronation strength. The location of compression explains pattern differences. On the dorsal wrist, the first extensor compartment houses APL and EPB. Their shared sheath can inflame with repetitive thumb abduction, pain over the radial styloid, and pain with thumb and fist ulnar deviation, reflect tendon and sheath mechanics. Lateral to this, a depression bordered by EPL and EPB APL. The anatomical snuff box overlies the scaphoid. The scaphoid's proximal pole has retrograde blood flow. Fractures across its waist risk a vascular necrosis of the proximal fragment. Tenderness in this hollow after a fall on an outstretched hand merits professional evaluation. Bone architecture dictates healing risk. Hand compartments convert linear pulls into delicate motion. Tensurae muscles, abductor pollicis brevis, flexor pollicis brevis, opponens pollicis rotate and flex the thumb metacarpal across the palm. Median nerve powers them. Remember the practical rule that the median controls thumb precision in the lateral palm. Adductor pollicis, deep head of FPB, and most small muscles are ulnar innervated. Hypothenar muscles, abductor, flexor, opponens digiminimi, cup the ulnar border. Interosi occupy dorsal and palmar spaces. Dorsal abductor fingers from the midline of the hand. Palmar adduct. Lumbricals arise from FDP tendons and insert into the extensor expansion. By pulling on the hood, they flex metacarpophalangeal joints while extending interphalangeal joints, a paradoxical motion that yields a gentle, precise tabletop position. This extensor hood wraps the dorsum of each finger and routes force among extensors, interosi, and lumbricals. Disruption shifts extension from one joint to another. Cutaneous maps mirror cable territories. Median nerve supplies palmar thumb, index, middle, and radial half of ring finger, plus dorsal fingertip skin. Of those digits, ulnar supplies ulnar palm and dorsal ulnar digits. Superficial radial supplies dorsolateral hand and thumb base. Motor summaries guide bedside clues. Loaf. Median controls lateral lumbricals, opponens pollicis, abductor pollicis brevis, and superficial head of flexor pollicis brevis, while ulnar powers interosi and adductor pollicis. Weak key pinch with thumb IP flexion. Frumment sign betrays ulnar dysfunction. Radial powers wrist and finger extensors. Wrist drop follows its palsy. Clinical patterns reflect conduit geometry. A midshaft humeral fracture may injure the radial nerve in the spiral groove. Wrist and finger extension weaken. Dorsal radial hand sensation dulls, but triceps often remains intact because branches arise proximally. Prolonged elbow flexion with pressure on the medial epicondyle narrows the cubital tunnel. Numbness in ring and little fingers and hand weakness develop. Interosi fatigue shows as finger abduction difficulty. Compression within Guyon's canal can spare dorsal ulnar hand sensation, served by a branch that leaves earlier, yet weaken intrinsic muscles. Location along the harness explains the split. Increasing pain out of proportion to exam, tense swelling, numbness, or progressive weakness after forearm trauma raises concern for compartment pressure. Compromising perfusion, prompt professional evaluation is essential because the rigid sleeves that guide tendons also limit expansion. Vessels create reliable arches. The brachial artery bifurcates into radial and ulnar arteries near the neck of the radius. Radial travels lateral, palpable at the distal forearm, passes through the anatomical snuff box, and contributes mainly to the deep palmar arch. Ulnar courses through the canal of Guyon and supplies most of the superficial palmar arch. Perforators and common digital arteries distribute along the fibrous septa. Collateral patterns maintain flow if one root narrows. Venous return parallels these paths via superficial cephalic, basilic, and deep veins linked by perforators. Their consistent landmarks aid safe cannulation but vary enough to reward patience. Tendon pulleys in the fingers, annular A and cruciform C bands, hold flexor tendons close to bone, preventing bowstringing and preserving moment arms. A2 and A4 are biomechanically critical. Injury alters grip strength and load distribution. Synovial sheaths nourish tendons via delicate vincula. Infection within a closed sheath can spread along the entire digit and into communicating spaces of the palm. Fusiform swelling, pain with passive extension, and tenderness along a tendon's course are concerning features that warrant prompt assessment. Anatomy explains rapid spread along low-resistance planes. Imaging respects the harness. Ultrasound shows tendons gliding within sheaths, detects nerve swelling at tunnels, and profiles dynamic impingement. Radiographs reveal alignment and carpal relationships. A disrupted galula arc suggests paralunate instability. MRI details TFCC, intrinsic ligaments, and denervation changes within muscles. Yet the mental model remains. 3 main cables, 2 forearm conduits with a shared membrane, osteofibrous tunnels at elbow and wrist, and intrinsic motors arranged in layered compartments under a tendon hood. A brief reflection. When you picture a harness with labeled branches and tight conduits, the hand's complexity feels orderly. Sensation and motion splits follow cables, not chaos. Hold the harness image. Next, the design repeats under weight. A pelvic ring bound by stout ligaments, a muscular floor that supports viscera, and passages that share space with vessels and nerves. While the lower limb begins its long lever, you feel weight pass from spine to legs through a firm ring and a soft sling. The bony ring, the pelvic girdle, transfers load. The sling, the pelvic floor, supports viscera and modulates pressure. Between them, stout ligaments turn shear into compression, so the sacrum locks into place and your steps feel steady. The bony pelvis consists of 2 hip bones and the sacrum with the coccyx below. Each hip bone is formed by ilium, ischium, and pubis, which fuse at the acetabulum, the cup for the femoral head. The sacrum, a wedge of fused vertebrae, fits between the auricular surfaces of the ilia at the sacroiliac SI joints. Its base faces superiorly, its apex inferiorly. Anteriorly, the pubic bones meet at a fibrocartilaginous joint, the pubic symphysis. Together, SI joints and the symphysis form a ring. When one point moves, the whole ring responds. The pelvic brim divides the greater false pelvis above from the lesser true pelvis below. The brim runs from the sacral promontory along the arcuate and pectineal lines to the pubic crest. The pelvic inlet is this brim viewed as an opening. The outlet is the inferior aperture bounded by the coccyx, sacrotuberous ligaments, and pubic arch. Between inlet and outlet, the cavity curves forward. This curvature matters for organ relationships and for the path of the fetal head in obstetrics. Pelvic shape varies across individuals. Anterior tilt, inlet dimensions, and outlet width influence how forces and viscera settle, yet the ring logic remains constant. Load transfer relies on joint orientation and ligament restraint. The SI joints are synovial anteriorly, with rough interlocking surfaces and syndesmotic posterior bands. They permit tiny glides and rotations. In nutation, the sacral base tips anteriorly relative to ilia. In counternutation, it tips posteriorly. Nutation tightens the sacrotuberous and sacrospinous ligaments, converting vertical load into compressive forces that close the joint. This mechanism stabilizes the ring during weight-bearing and childbirth. The iliolumbar ligaments tie L5 to the iliac crest, resisting shear at the lumbosacral junction. The interosseous SI ligament, deep and strong, is the major bond between sacrum and ilium. Superficial posterior SI ligaments span the same region and are palpable as firm bands near the posterior superior iliac spines. The sacrotuberous and sacrospinous ligaments also sculpt exits. By running from sacrum to ischial tuberosity, sacrotuberous, and sacrum to ischial spine, Sacrospinous, they transform the greater sciatic notch into the greater sciatic foramen and the lesser notch into the lesser sciatic foramen. Muscles and neurovascular bundles use these gates predictably. Piriformis leaves the pelvis through the greater sciatic foramen to the gluteal region. Superior and inferior gluteal vessels and nerves pass above and below piriformis respectively. The pudendal nerve S2-S4. The main somatic nerve of the perineum exits via the greater sciatic foramen, hooks around the ischial spine, and re-enters through the lesser sciatic foramen to travel in the pudendal canal along the obturator internus fascia toward the perineum. The obturator foramen, formed by pubis and ischium, is largely closed by the obturator membrane, leaving a small obturator canal at its superior margin. Through this canal pass the obturator nerve and vessels to the medial thigh. This direct corridor explains why pelvic pathology can present as medial thigh pain. Lateral to the foramen, the acetabulum receives the femoral head, its horseshoe-shaped lunate surface bears load, and its labrum deepens the socket. The hip joint's orientation, acetabulum anterior infralateral, femoral neck angled and anteverted, sets the lower limb's power line and will matter when the thigh arrives. Arterial supply follows name branches from the internal iliac artery. A posterior division commonly gives the iliolumbar and lateral sacral arteries and the superior gluteal artery through the greater sciatic foramen above piriformis. An anterior division often gives the inferior gluteal artery below piriformis, obturator artery through the obturator canal, and internal pudendal artery, which accompanies the pudendal nerve to the perineum. In some individuals, an aberrant obturator artery arises from the inferior epigastric artery and crosses the superior pubic ramus. This variant lies near surgical fields behind the pubic bone. Venous return parallels arteries to the internal iliac veins with plexuses around pelvic organs that can engorge under pressure changes. The pelvic floor forms a muscular diaphragm that closes the outlet and supports organs. Its main component is levator ani, traditionally described as puborectalis, pubococcygeus, and iliococcygeus. Puborectalis forms a U-shaped sling from pubis around the anorectal junction, maintaining the anorectal angle that helps continence by kinking the canal at rest. Pubococcygeus and iliococcygeus form broader sheets from pubis and tendinous arch to coccyx and anococcygeal raphe. Posteriorly coccygeus ischiococcygeus lies over the sacrospinous ligament from ischial spine to sacrum and coccyx. Together these muscles support pelvic organs, elevate the pelvic floor during increases in intra-abdominal pressure, and coordinate with the urethral and anal sphincters for continence. The perineum is the region inferior to the pelvic floor, bounded by the bony outlet and divided by a line between ischial tuberosities into urogenital anterior and anal posterior triangles. A tough sheet, the perineal membrane, spans the urogenital triangle, providing attachment for external genital structures and the external urethral sphincter complex. Deep to this membrane lies the deep perineal pouch with muscles that assist continence. The anal triangle contains the anal canal and the ischio-anal fasciae, fat-filled spaces on either side of the canal that allow expansion during defecation. The pudendal nerve and internal pudendal vessels travel within the pudendal canal on the lateral wall of the fasciae, giving inferior rectal branches and perineal branches that supply sensation, motor control, and erectile tissues. Organ relationships follow the ring. In females, bladder rests posterior to pubic symphysis. Uterus lies between bladder and rectum, supported by ligaments that are condensations of pelvic fascia, including cardinal and uterosacral ligaments. Ovaries and uterine tubes occupy the lateral pelvic wall near the ovarian vessels in the suspensory ligament of the ovary. Uterine vessels cross above the ureter near the cervix. Water under the bridge as a spatial memory. In males, bladder sits posterior to pubic bones. The prostate encircles the proximal urethra inferior to bladder. Seminal vesicles and vas deferens lie posterior to bladder and anterior to rectum. The ureters descend retroperitoneally along the lateral pelvic wall toward the bladder base in both sexes. Their oblique intramural course helps prevent reflux during bladder contraction. Nerves mirror function. Sacral plexus branches, L4-S4, on the anterior surface of piriformis give superior and inferior gluteal nerves, the sciatic nerve to the posterior thigh and below, and pudendal nerve to the perineum. Pelvic splanchnic nerves, S2, S4, carry parasympathetic fibers to pelvic viscera, promoting bladder contraction and rectal motility. Sympathetic fibers via hypogastric plexuses modulate vascular tone and the internal sphincters. Somatic autonomic coordination allows storage and release phases to alternate smoothly. Disruption at any level alters pattern rather than producing randomness. A clinical vignette shows ring and sling at work. After childbirth, a person notices pelvic heaviness late in the day and urinary urgency with occasional leakage when coughing. Examination reveals descent of anterior vaginal wall and tenderness along the puborectalis sling. Pregnancy and delivery load the levator, anatomical, and connective supports. Tissue stretch and avulsion can reduce resting support and alter reflex timing during pressure spikes. Red flags: severe pelvic pain with fever, sudden inability to urinate or defecate, new saddle area numbness or progressive leg weakness, require prompt professional care. The same region also hosts neurological corridors whose compression changes function beyond the floor. Pelvic fractures follow ring logic. A single break is uncommon. Energy often produces two or more disruptions, anterior at the symphysis or pubic rami and posterior at SI or sacral regions. Posterior injury threatens stability because most load crosses the posterior arch. Associated bleeding can be significant due to venous plexuses and cancellous bone. After high-energy trauma with pelvic pain, deformity, hypotension, or neurological changes, urgent evaluation is essential. Anatomy explains both the pattern and the potential for concealed blood loss. Imaging maps these structures. Anteroposterior pelvic radiographs survey the ring, inlet and outlet views, profile anterior, posterior, and vertical displacement. CT defines fracture lines and furinal paths. MRI demonstrates organ relationships, pelvic floor integrity, and neural tunnels. Ultrasound assesses bladder, uterus, and pregnancy-related structures and can guide evaluation of perineal soft tissues. Yet the mental model remains a keystone arch sacrum locked by tie beams, ligaments inside a ring, hip bones, suspended over a fabric hammock, levator ini, that supports and seals. A brief reflection, picturing the pelvis as stone ring and fabric sling, turns a crowded region into a coherent support system. Steadiness comes from compression above and tone below. Your hand now reaches from the ring to its longest lever, the femur, where compartments, cruciate ligaments, and menisci distribute force as the knee turns a straight column into a stable hinge. How does power cross a joint that must also twist and absorb? You feel a long lever swing from the pelvic ring, then hinge and glide over a padded platform. The thigh and knee behave like a door with cross straps and two C-shaped washers. The femur is the moving leaf, the tibial plateau the fixed jamb, the cruciates the cross straps, and the menisci the resilient washers that spread force. At the thigh's core, three osteofascial compartments organize power and control. Anterior holds the knee extensors, the quadriceps femoris, rectus femoris, vastus medialis, vastus intermedius, vastus lateralis, and sartorius, supplied by the femoral nerve, L2, L4. Medial houses the adductors, longus, brevis, magnus, gracilis, and obturator externus, supplied mainly by the obturator nerve, L2, L4. Posterior contains the hamstrings, semitendinosus, semimembranosus, and the long head of biceps femoris, supplied mostly by the tibial division of the sciatic nerve, L4, S3, with the short head of biceps femoris from the common fibular division. Their tendons cross the knee to steer the hinge while the quadriceps extend the lever. Arteries mirror the plan. The femoral artery passes beneath the inguinal ligament into the femoral triangle bounded by inguinal ligament, sartorius, and adductor longus, gives the profunda femoris, deep artery of thigh, with medial and lateral circumflex branches around the femoral neck, then continues through the adductor canal beside the saphenous nerve. At the adductor hiatus, it becomes the popliteal artery behind the knee, issuing a genicular network that rings the joint and sustains flow through flexion. Below, the popliteal divides into anterior tibial and tibioperoneal trunk, continuing as posterior tibial and fibular arteries. Veins accompany these paths. The great saphenous ascends superficially along the medial limb to the groin. The distal femur presents two rounded condyles separated by an intercondylar notch and a trochlear groove for the patella. The proximal tibia offers two articular plateaus, medial more concave, lateral more convex, separated by intercondylar eminences where cruciate ligaments and meniscal horns anchor. The fibular head lies posterolateral and does not directly bear knee joint loads. It serves as an attachment site and a passage landmark for the common fibular nerve. The tibiofemoral joint primarily flexes and extends, but also permits small rotation and translation. In terminal extension, the screw-home mechanism locks the hinge. In open chain, the tibia externally rotates relative to the femur. In closed chain, the femur internally rotates on the tibia. This results from unequal condylar shapes and tensioning of the anterior cruciate ligament, ACL. Popliteus initiates unlocking into flexion by internally rotating the tibia or externally rotating the femur. These subtle rotations center contact, reduce energy cost in stance, and set collateral ligaments to optimal length. Meniscofibrocartilaginous crescents that deepen the tibial surface and distribute load. The medial meniscus is C-shaped and more fixed because it blends with the deep fibers of the medial collateral ligament, MCL, and the joint capsule. The lateral meniscus is more O-shaped and mobile, partly due to popliteus attachments that retract it during flexion. Peripheral meniscal tissue receives blood from genicular branches, the red zone, while the inner free edge is avascular, the white zone. Functions include increasing contact area, thereby lowering stress, aiding lubrication, and providing proprioceptive feedback via mechanoreceptors at their horns. Tears follow mechanics. Twisting on a planted foot can trap a meniscal fragment between condyle and plateau, provoking joint line pain or catching. Complex degenerative tears reflect cumulative shear. 4 major ligaments resist predictable forces. The ACL runs from the anterior tibial plateau, medial to the lateral spine, to the posteromedial aspect of the lateral femoral condyle. It resists anterior translation of the tibia and contributes to controlling internal rotation and valgus varus coupling. The posterior cruciate ligament, PCL, runs from the posterior tibial plateau to the lateral face of the medial femoral condyle. It resists posterior translation and helps guide flexion. The MCL extends from the medial femoral epicondyle to the tibia and blends with the capsule and medial meniscus. It resists valgus stress. The lateral collateral ligament, LCL, a cord from the lateral femoral epicondyle to the fibular head, resists varus stress and is extracapsular. Around them, the posterolateral corner popliteus tendon, popliteofibular ligament, arcuate complex, and LCL stabilizes against external rotation and varus. Injury here produces a distinctive opening on specific stress tests and can accompany cruciate tears. The patellofemoral joint is a pulley within the extensor mechanism. The patella, a sesamoid bone within the quadriceps tendon, increases the moment arm for extension and centralizes tendon forces in the trochlear groove. The quadriceps tendon continues as the patellar ligament to the tibial tuberosity, medial and lateral retanicula. Expansions from vasti stabilize tracking. Groove depth and patellar shape vary. Lateral facets often bear higher compressive loads during early flexion. The Q angle, a frontal plane measure between the quadriceps vector and patellar tendon, summarizes alignment influences from pelvis, femur, and tibia. Excessive lateral vector can bias tracking and stress lateral soft tissues. Cartilage compression rises with flexion angles. Descent on stairs or prolonged sitting can provoke anterior knee discomfort in susceptible patterns. Bursae reduce friction around bony points. Prepatellar bursa lies between skin and patella. Superficial and deep infrapatellar bursae flank the patellar ligament. Anserine bursa cushions the conjoined tendons of sartorius, gracilis, and semitendonsus. The pes anserinus against the medial tibia. A large synovial recess communicates posteriorly with the semimembranosus bursa. When joint fluid tracks into the popliteal recess, a distended synovial outpouching can appear in the popliteal fossa, often called a Baker cyst, reflecting intra-articular pressure rather than a separate sac. Nerves bracket the joint from above and behind. The femoral nerve supplies quadriceps. Its long saphenous branch is purely sensory along the medial leg and foot. The sciatic nerve divides near the popliteal fossa into tibial and common fibular nerves. The tibial nerve continues centrally through the fossa to the posterior leg. The common fibular nerve courses laterally around the fibular neck, where it is vulnerable to compression or traction. foot dorsiflexion and aversion weakness follow its injury. The popliteal fossa itself is a diamond behind the knee, bounded by hamstring tendons above and heads of gastrocnemius below. Within lie popliteal artery and vein deep and central, with the tibial nerve superficial to the vessels. Clinical patterns arise from this architecture. A sudden pivot with valgus and internal rotation can produce a pop, immediate swelling, and a sense of giving way, an ACL rupture. Because the MCL and medial meniscus are neighbors, combined injuries occur in valgus loads. A dashboard impact to the proximal tibia can drive it posteriorly, injuring the PCL. Posterior sag of the tibia and flexion is a bedside clue. A blow to the lateral knee can strain or tear the MCL. A varus blow can compromise the LCL and posterolateral corner. Twisting with a planted foot, followed by joint line pain and mechanical catching or locking, suggests a meniscal tear. Inability to bear weight after trauma, visible deformity, fever with a hot swollen knee, numbness, cold foot, or rapidly increasing pain and tightness are warning signs that warrant prompt professional evaluation. Maps guide suspicion but do not replace assessment. Gait explains load sharing. In early stance, the quadriceps control knee flexion eccentrically, restraining the hinge as the heel strike transitions to foot flat. Hamstrings and gastrocnemius help decelerate the femur and stabilize the posterior capsule. In mid-stance, ligaments and menisci share compressive load as the line of force passes near the knee center. In terminal stance, the screw-home lock lowers muscular demand. During swing, hamstrings flex the knee to clear the foot, then quadriceps extend before heel contact. Deviations upstream, pelvic tilt, or downstream, pronation timing, alter patellofemoral tracking and tibial rotation, redistributing stress across cartilage and soft tissues. Imaging reads the hinge. Radiographs AP lateral tunnel and sunrise/merchant views, profile joint spaces, alignment, and patellar congruence. MRI depicts cruciates as low-signal bands, meniscal triangles with clear roots and horns, bone marrow edema patterns that mirror injury mechanics, for example, lateral femoral condyle contusion with ACL injury. Ultrasound can view effusions and superficial tendons and bursae. CT clarifies fracture geometry. Yet the door and straps picture remains primary: two rounded rollers on two padded plates, cross straps preventing translation, side straps resisting opening, and a pulley in front that boosts extension. A quiet vignette connects pieces. A trail runner missteps on a rock, feels a twist and immediate medial knee pain, then later experiences catching when rising from a chair. Examination localizes tenderness to the medial joint line, with pain on combined flexion and rotation. Ligaments feel stable. The washers and straps model focuses attention on the medial meniscus and its anchored edge to the MCL. Sudden swelling, locking in extension, fever, or calf swelling with shortness of breath demands timely evaluation. Knee symptoms can reflect joint, tendon, bursa, or even vascular causes that share the same narrow corridors. Reflection stays brief. When you visualize a door that locks itself at the end range with two crossing straps and two resilient washers, complex patterns reduced to forces you can name. The lever continues below the hinge into twin bones tied by a membrane. A mortise that grips a pulley-like talus, a powerful calf that stores energy, and arches that turn impact into spring. How do the leg, ankle, and foot convert ground reaction into forward motion so efficiently? You trace two long rails down the shank, tibia medially bearing most weight, fibula laterally acting as a strut, and a pulley-shaped talus gripped by a bony mortise. Behind, a thick cable from a three-headed calf. The triceps surae stores energy with every step and releases it in a clean push. Beneath, arches made of bone, ligaments, and tendons turn ground reaction forces into forward motion with quiet efficiency. The leg is organized into four osteofascial compartments by the interosseous membrane and deep fascia. Anterior compartment, tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis peroneus tertius dorsiflexes the ankle and extends toes, innervated by the deep fibular peroneal nerve. Its artery is the anterior tibial, which continues onto the dorsum as dorsalis pedis. Lateral compartment, fibularis longus and brevis, everts the foot and assists plantar flexion supplied by the superficial fibular nerve. Their tendons pass posterior to the lateral malleolus within a retinacular tunnel. Posterior compartments are split by the transverse intermuscular septum, superficial gastrocnemius, soleus, plantaris, and deep tibialis posterior, flexor digitorum longus, flexor hallucis longus. The tibial nerve and posterior tibial vessels course in the deep posterior compartment. A large branch, the fibular peroneal artery, runs along the fibula. This layout explains common syndromes. A tight anterior sleeve causes pain with dorsiflexion heavy activity. A tense deep posterior sleeve can threaten neurovascular flow. The ankle joint talocrural is a hinge between the distal tibia fibula mortis and the trochlea of the talus. Dorsiflexion tightens the mortis over the talus's wider anterior dome. Plantar flexion relaxes it. Stability relies on congruent bone and 3 ligament systems. Medially, the deltoid ligament, fan-shaped, deep and superficial layers from the medial malleolus, resists eversion and external rotation. Its depth and bony buttress make pure eversion sprains less common. Laterally, the anterior talofibular ligament, ATFL, resists inversion and plantar flexion. The calcaneofibular ligament, CFL, resists inversion in neutral. The posterior talofibular ligament stabilizes in dorsiflexion and posterior translation. Proximally and distally, the tibiofibular syndesmosis, an interosseous ligament with anterior and posterior tibiofibular ligaments, keeps the mortise intact. Injury here, high ankle sprain, destabilizes the ring, more than a simple lateral sprain because spreading of the mortise compromises grip on the talus. Below the talus, the subtalar joint, talocalcaneal, permits inversion and eversion via a complex of posterior, middle, and anterior facets, and the interosseous talocalcaneal ligament within the sinus tarsi. Together with the transverse tarsal joints, talonavicular and calcaneocuboid, it couples rear foot and midfoot to adapt to uneven ground. In pronation, rear foot eversion with forefoot abduction and dorsiflexion, the midfoot unlocks for shock absorption. In supination, rear foot inversion with forefoot abduction and plantar flexion, it locks for a rigid lever at push-off. This changeable stiffness is the foot's core trick, a soft landing, a stiff departure. The triceps surae is a 2-layer engine. Gastrocnemius has medial and lateral heads crossing the knee and ankle, generating powerful plantar flexion, especially when the knee is extended. Soleus arises from tibia and fibula, acts regardless of knee angle, and is rich in fatigue-resistant fibers that stabilize stance. The plantaris, thin with a long tendon, varies and contributes little force. Their tendons merge into the calcaneal Achilles tendon, which inserts on the calcaneal tuberosity. Collagen fibers spiral, storing elastic strain energy during stance. Dorsiflexion loads the tendon, then recoil assists push-off, reducing muscular energy cost. Sudden force to a loaded tendon can tear fibers. People describe a sharp pop and the sense of being kicked. Inability to plantar flex strongly or stand on tiptoe deserves prompt evaluation because delayed care complicates recovery. Medially at the ankle, tendons pass in a predictable order, posterior to the medial malleolus. Remember the sequence from anterior to posterior. Tibialis posterior, flexor digitorum longus, posterior tibial artery and veins. Tibial nerve, flexor hallucis longus. This narrow osteofibrous tunnel, the tarsal tunnel, is roofed by the flexor retinaculum. Swelling within can compress the tibial nerve, producing burning pain or numbness in the plantar foot, often sparing the heel if the calcaneal branch arises proximally. Laterally, the fibular tendons pass beneath the superior and inferior fibular retinacula. Subluxation after retinacular injury causes snapping at the lateral malleolus with eversion weakness. The plantar foot is an engineered spring. 3 arches share load. Medial longitudinal calcaneus talus navicular cuneiforms, first 3 metatarsals, lateral longitudinal calcaneus cuboid lateral metatarsals, and transverse across cuneiforms and bases of metatarsals. Static supports include the plantar aponeurosis, a thick central band from calcaneus to proximal phalanges, the plantar calcaneonavicular spring ligament beneath the head of the talus, the long and short plantar ligaments, and joint capsules. Dynamic supports include tibialis posterior, lifting the navicular and medial arch, fibularis longus, depressing the first metatarsal base, and supporting the transverse arch by crossing the sole. intrinsic foot muscles that fine-tune toe positions, and the windlass mechanism. As the toes dorsiflex during push-off, the plantar aponeurosis winds around the metatarsal heads, shortening the distance between calcaneus and metatarsals and stiffening the arch for propulsion. Morning heel pain localized near the medial calcaneal tubercle often reflects overload at the aponeurosis origin. Red flags, fever, open wound, severe rest pain, numb or cold toes call for timely professional care beyond pattern recognition. Cutaneous and motor maps are orderly. The temple nerve becomes medial and lateral plantar nerves in the sole. Medial plantar supplies most medial sole sensation and motor to abductor hallucis, flexor digitorum brevis, flexor hallucis brevis, and the first lumbrical. Think median analog precision for the big toe. Lateral plantar supplies lateral sole sensation and most intrinsic muscles. The common fibular nerve divides into superficial fibular sensory to most dorsum of foot, motor to fibularis longus and brevis, and deep fibular motor to anterior compartment sensory in a small first web space. A lesion at the fibular neck can cause foot drop, weak dorsiflexion and toe extension with a steppage gait. New weakness, progressive numbness, or inability to bear weight after trauma merits prompt evaluation. The tunnels are narrow and the sleeves firm. Arterial roots mirror compartments. The popliteal artery divides into anterior tibial to dorsalis pedis and posterior tibial, giving fibular artery, then bifurcating to medial and lateral plantar arteries. Dorsalis pedis crosses the dorsum between the extensor hallucis longus and extensor digitorum longus tendons and joins the plantar arch through the deep plantar artery. Plantar and dorsal arches give metatarsal and digital branches. Superficial veins, great and small saphenous, run in the subcutaneous layer with valves and perforators to the deep system. Sudden calf swelling with warmth and tenderness, especially with shortness of breath or chest pain, is concerning for venous thrombosis and pulmonary embolism and requires urgent professional assessment. Anatomy explains how deep and superficial systems communicate but cannot grade risk at home. Clinical patterns follow mechanics. An inversion sprain and plantar flexion commonly strains the ATFL and may involve the CFL, swelling and tenderness, localize anterolateral. Eversion injuries can strain the deltoid and with syndesmotic tears widen the mortise. Pain higher near the distal tibiofibular joint suggests this pattern. Stress along the medial tibial border and runners reflects repetitive traction at the deep posterior compartment attachments and load management across the tibia. Focal bone tenderness after a training surge warrants evaluation to exclude stress fracture. Pain localized to the sinus tarsi with instability feelings suggests subtalar involvement. Difficulty pushing off with localized pain posteromedially toward the navicular raises suspicion for tibialis posterior dysfunction with arch collapse patterns. Severe deformity, open wounds, fever with a red foot, rapidly increasing pain and tightness, or pale, numb toes are urgent signals. Tight sleeves and critical corridors leave little reserve. Imaging translates these ideas to pictures. Ankle radiographs, AP, mortise, lateral, assess the clear space and joint congruity. Weight-bearing films reveal arch integrity and midfoot alignment. Ultrasound shows tendon glide and synovial sheaths in real time. MRI depicts ligament fibers, osteochondral lesions of the talar dome, and plantar fascia thickness with surrounding edema. CT clarifies comminuted calcaneal or pylon fractures where joint surfaces matter. Yet the simple model remains: rails, mortise, pulley, springy cable, and arches that lock and unlock on cue. A short thought lingers, feeling the leg and foot as a tuned spring. Soft when you land, stiff when you leave. Turn steps into a quiet sequence rather than effort. Up the line, that spring depends on time delivery and return of blood. Now you enter the central pump with its valves and dedicated vessels, the chambers of the heart and the paths of the great arteries and veins that keep the circuit steady. You picture a four-roomed pump, each chamber opening and closing in precise sequence, valves like doors whose hinges and leaflets shape the direction of flow. From this muscular engine, thick elastic trunks carry blood away, thin, compliant channels return it. The heart and great vessels sustain continuous circulation through rhythm, geometry, and coordinated contraction. The heart lies in the middle mediastinum, tilted with its apex pointing leftward and inferiorly. Its surface anatomy shows a base, posterior, mainly left atrium, and apex, tip of the left ventricle, sternocostal, diaphragmatic, and pulmonary surfaces. The pericardium surrounds it, a fibrous outer sac anchored to diaphragm and sternum, and a serous lining with parietal and visceral layers between is a thin lubricated space. Tethering ensures that when the diaphragm moves, the heart shifts but does not wander. Internally, the heart has right and left atria receiving blood, and right and left ventricles ejecting it. The right atrium accepts systemic venous return from superior and inferior venae cava and coronary sinus. It contains the fossa ovalis, remnant of fetal foramen ovala, and the sinoatrial SA node near the superior vena cava entry. The right ventricle forms most of the anterior surface, pumping through the pulmonary valve into the pulmonary trunk. The left atrium posterior receives 4 pulmonary veins carrying oxygenated blood. The left ventricle, thick-walled and conical, forms the apex and ejects through the aortic valve into the ascending aorta. The interventricular septum, muscular below and membranous above, divides ventricles and hosts part of the conduction system. Valves direct flow. The tricuspid valve lies between right atrium and ventricle, with 3 leaflets tethered by chordae tendineae to papillary muscles that contract in systole to prevent prolapse. The pulmonary valve has 3 semilunar cusps at the right ventricular offlow. The mitral bicuspid valve has anterior and posterior cusps guarding the left atrioventricular orifice, its chordae attached to papillary muscles of the left ventricle. The aortic valve, with 3 semilunar cusps, sits at the left ventricular offlow. Behind its cusps are the aortic sinuses from which the coronary arteries arise. Valve timing produces heart sounds. Closure of atrioventricular valves, S1, at systole's onset. Closure of semilunar valves, S2, at diastole's onset. Conduction tissue coordinates sequence. The SA node initiates depolarization. Impulses spread through atrial muscle and converge on the atrioventricular AV node in the interatrial septum. The AV node delays conduction, allowing atrial emptying before ventricular contraction. The impulse descends the atrioventricular bundle of Hysda, dividing into right and left bundle branches along the interventricular septum, then into Purkinje fibers that rapidly depolarize ventricular walls. This hierarchy ensures atrio contract first, ventricles second, from apex upward, efficiently ejecting blood. Coronary circulation nourishes the myocardium. The right coronary artery, RCA, arises from the right aortic sinus, runs in the atrioventricular groove, and gives the sinoatrial nodal branch, often right marginal branch, and posterior interventricular branch, posterior descending. The left coronary artery, LCA, arises from the left sinus, soon dividing into anterior interventricular, left anterior descending, LAD, and circumflex branches. The LAD descends in the anterior interventricular groove, giving diagonal and septal branches. The circumflex runs in the atrioventricular groove, giving obtuse marginals. Coronary dominance refers to which artery gives the posterior interventricular branch, most commonly RCA. Venous return proceeds via the coronary sinus into the right atrium. Because flow occurs mainly in diastole, tachycardia can reduce coronary perfusion. Occlusion of proximal branches produces regional ischemia and infarction patterns, recognizable on imaging and electrocardiography. Great vessels define circuits. The superior vena cava drains head, neck, upper limbs, and chest. The inferior vena cava drains abdomen, pelvis, and lower limbs. The pulmonary trunk arises from the right ventricle, bifurcates into right and left pulmonary arteries, and carries deoxygenated blood to lungs. 4 pulmonary veins return oxygenated blood to the left atrium. The ascending aorta arises from the left ventricle, continues as arch with 3 branches, brachiocephalic trunk, giving right subclavian and right common carotid, left common carotid, and left subclavian. The arch continues as descending thoracic aorta, which gives posterior intercostal arteries and visceral branches to esophagus, bronchial tree, and pericardium before passing into the abdomen. Venous return from the heart wall itself includes the Bosnian veins, small vessels opening directly into chambers, anterior cardiac veins draining directly to the right atrium, and the major coronary veins converging on the coronary sinus. Venous return from systemic organs converges via cava. Unidirectional valves and veins of limbs prevent reflux and assist upward flow with muscular contraction. When these valves fail, venous dilation and pooling occur. Clot formation within deep veins poses risk of embolism if fragments reach pulmonary arteries. Sudden breathlessness with chest pain or collapse requires immediate professional evaluation. Clinical correlations reflect architecture, valvular stenosis, narrowing, or regurgitation, incompetence, alters chamber pressure and volume. Murmurs are turbulent sounds produced when valves do not open or close cleanly. Myocardial ischemia arises from coronary narrowing or occlusion, crushing chest pain radiating to arm or jaw. Shortness of breath, diaphoresis, or syncope are urgent signs requiring emergency care. Conduction disturbances produce rhythm changes from extra beats to dangerous arrhythmias because the impulse system depends on specific pathways through fibrous tissue. Enlargement of chambers shifts apex beat location and alters silhouette on imaging. Imaging demonstrates structures. Chest radiographs show cardiac silhouette and great vessel contours. Echocardiography visualizes chambers, valves, wall motion, and flow patterns with Doppler. CT angiography maps coronary arteries. MRI delineates myocardial tissue and viability. Yet the mental image remains a four-room pump with swinging leaflets, powered by synchronized depolarization, supplied by surface arteries, and linked to trunks that distribute and return blood. A vignette illustrates the map. A middle-aged person develops sudden left-sided chest pressure, radiating to the left arm with sweating and nausea. The symptom pattern raises concern for myocardial ischemia. The coronary distribution explains why supply restriction produces pain. New severe chest pain, fainting, sudden breathlessness, or palpitations with dizziness are always reasons for urgent professional assessment. Reflection stays gentle. When you picture the heart as four orderly rooms with doors opening in rhythm and pipes leading out and back, the continuous flow seems less mysterious and more inevitable. The circuit does not end at the arch next. Thick arteries branch to limbs, thin veins climb back, and special valves and muscles in the periphery cooperate to return blood efficiently against gravity. You picture rivers branching from a central trunk, coursing through valleys and returning by paired channels. Thick-walled arteries carry pulsatile flow outward. Thin-walled veins, often with valves, channel low-pressure blood back toward the heart. Together, the peripheral circulation distributes nutrients and retrieves wastes, maintaining balance across distance and posture. Arteries are elastic conduits that branch predictably. From the arch, the brachiocephalic trunk gives right common carotid and right subclavian. The left common carotid and left subclavian arise directly. Subclavians become axillary arteries at the first rib, then brachial arteries at the arm. At the cubital fossa, brachial divides into radial and ulnar arteries. These form the superficial and deep palmar arches, supplying digital arteries. Lower limb parallels, the common iliac divides into external and internal iliac arteries. External continues as femoral beneath the inguinal ligament, passing through the adductor hiatus to become popliteal. Popliteal divides into anterior and posterior tibial arteries, the former continuing as dorsalis pedis, the latter into plantar arteries. These branching patterns ensure each limb segment has at least two roots, proximal trunk and distal arch. Veins are more variable but form superficial and deep systems. In upper limbs, superficial veins, cephalic laterally, basilic medially, drain into axillary via median cubital vein at the elbow, a common access site. Deep veins accompany arteries, veins concomitantes, aided by arterial pulsation. In lower limbs, the great saphenous vein ascends medially to join femoral vein. The small saphenous ascends posteriorly to popliteal vein. Valves within superficial and perforating veins prevent reflux. Failure of valves produces varicosities, visible tortuous veins from pooling and pressure. Superficial veins are accessible for access. Deep veins handle most return. Clot formation in deep veins. Deep vein thrombosis can embolize to pulmonary arteries. Acute calf swelling, redness, warmth, or sudden chest pain and breathlessness warrant immediate evaluation. Capillaries link distribution and return. They are thin-walled endothelial tubes where exchange occurs. Continuous capillaries in muscle and skin allow selective permeability. Fenestrated capillaries in kidney glomeruli and gut villi facilitate filtration and absorption. Sinusoidal capillaries in liver, spleen, and marrow allow passage of cells and large molecules. Precapillary sphincters regulate entry, responding to local oxygen, carbon dioxide, and metabolites. Venules collect outflow coalescing into veins. This microvascular network ensures delivery matches demand. In exercising muscle, arterioles dilate, sphincters open, and flow increases many-fold. Mechanisms assist venous return. The skeletal muscle pump contraction compresses veins, valves direct flow proximally. The respiratory pump, diaphragm descent during inspiration lowers thoracic pressure and raises abdominal pressure, drawing blood upward. Smooth muscle and vein walls modulates tone, aided by sympathetic innervation. Because pressure is low, obstruction, valve failure, or immobility easily impairs return. Prolonged sitting or standing can swell ankles by pooling, walking, or calf exercises restore pump action. Peripheral arteries supply predictal territories. Radial pulse at wrist, dorsalis pedis on foot dorsum, posterior tibial behind medial malleolus are accessible points. Loss or diminution of pulse beyond a site suggests upstream obstruction. Acute limb ischemia presents with pain, pallor, pulselessness, paralysis, paresthesia, and poikilothermia. The 6 Ps. Any sudden cold, pale, painful limb is an emergency requiring immediate professional care. Chronic narrowing produces claudication, reproducible muscle pain with exertion relieved by rest. Collateral channels can enlarge gradually, but not suddenly. Special circuits balance systemic flow. The portal system directs venous blood from gut, pancreas, and spleen to liver via the portal vein. Here nutrients, toxins, and metabolites are processed before systemic return. Collaterals between portal and systemic veins at esophagus, rectum, and abdominal wall can enlarge in portal hypertension, producing varices or caput medusae. Their rupture risks hemorrhage. In limbs, arteriovenous anastomosis in fingers and toes help thermoregulation. Sympathetic tone controls shunt opening to conserve or dissipate heat. Neurovascular bundles travel together in fascial planes. Artery, vein, nerve bound by connective tissue. At joints, arterial rings, collaterals ensure supply despite flexion or compression. Around the elbow, superior and inferior ulnar collateral arteries link with recurrent branches. Around the knee, genicular arteries form an anastomotic network. These redundancies explain why distal flow can persist despite ligation or gradual narrowing, but collapse with acute occlusion. Clinical correlations reflect geometry. Superficial vein thrombophlebitis produces tender cords but rarely embolizes. Deep vein thrombosis is more dangerous. Chronic venous insufficiency produces ankle swelling, skin changes, and ulcers from sustained high venous pressure. Arterial disease reduces pulses, thins skin, and slows wound healing. Small traumas can ulcerate. In diabetics, combined neuropathy and vascular compromise increase risk of non-healing foot lesions. Sudden neurological symptoms, weakness, facial droop, speech change, reflect occlusion in cerebral arteries, different branch but same arterial logic. Chest pain on exertion that resolves with rest can reflect narrowed coronary arteries. Acute severe chest pain at rest is a red flag for urgent care. Imaging visualizes paths. Doppler ultrasound measures flow and detects obstruction in limb vessels. CT or MR angiography shows arterial branching and occlusions. Venography and cross-sectional imaging reveal venous thrombi, yet the image remains simple: thick, branching pipes distributing outward, thin valve channels returning inward, a low-pressure system assisted by pumps and posture. A quiet reflection: when you see blood flow as a branching river with steady return channels, the body's circulation feels like a landscape that continuously renews itself. Now lift your gaze to the lungs, where every drop must trade gases in countless tiny sacs, and where airways branch like a tree that mirrors the vascular map. You picture 2 soft cones within the chest, their surfaces sliding against pleura, their interiors branching like trees. Each breath draws air through a trunk that divides into finer and finer passages until it ends in millions of thin-walled sacs where blood and air meet across a microscopic film. The lungs and bronchial tree are both filters and exchangers, elastic reservoirs that expand and recoil in steady rhythm. The lungs occupy the pleural cavities, right and left, separated by the mediastinum. The right lung has 3 lobes, superior, middle, and inferior, divided by horizontal and oblique fissures. The left lung has 2 lobes, superior and inferior, divided by an oblique fissure with a lingula projecting like a tongue over the heart. Surfaces adapt to neighbors, costal surfaces curve against ribs, diaphragmatic bases rest on domes, mediastinal surfaces bear impressions from heart, aorta, esophagus, and great vessels. The apex rises into the root of the neck above the first rib, the base sits on the diaphragm, moving with each breath. Pleura form the lining and covering. Parietal pleura adheres to the chest wall, diaphragm, and mediastinum. Visceral pleura invest the lung surface. They meet at the hilum where root structures enter and exit. Between is the pleural cavity with a thin film of fluid allowing glide while maintaining adhesion by surface tension. Reflections create recesses. The costodiaphragmatic recess at the base deepens during inspiration and is a common site where fluid collects. The costomediastinal recess, especially on the left, admits lung expansion beside the heart. In health, these spaces are potential. In disease, air pneumothorax or fluid effusion, blood pus can accumulate, altering mechanics. Sudden chest pain and breathlessness with tracheal shift or asymmetric expansion require urgent professional evaluation. Airways branch from the trachea, which begins at the cricoid cartilage C6, passes through the thorax, and bifurcates at the carina T4-T5. The trachea is supported by C-shaped rings of hyaline cartilage open posteriorly where trachealus muscle spans. At the carina, right and left main bronchi arise. The right main bronchus is wider, shorter, and more vertical. Foreign objects more often enter here. The left is narrower, longer, and more oblique. Each main bronchus enters a lung route with pulmonary artery, pulmonary veins, lymphatics, and nerves. Within lungs, bronchi branch into lobar secondary bronchi. 3 on the right, 2 on the left, supplying lobes, then into segmental tertiary bronchi, each supplying a bronchopulmonary segment. Segments are pyramidal units of lung tissue with apex at the hilum and base at the surface. Each has its own segmental bronchus and artery, with intersegmental veins in connective tissue planes. These segments are functionally discrete. Disease or surgery can remove one without collapsing others. Typically, the right lung has 10, the left 8 to 10, depending on fusion of apical and basal units. Bronchi continue branching into smaller bronchioles, lat 1 mm, lacking cartilage, then terminal bronchioles marking the end of conducting airways. Beyond lie respiratory bronchioles with occasional alveoli in their walls, leading to alveolar ducts and sacs packed with alveoli. Alveoli are thin-walled chambers where gas exchange occurs. Type 1 pneumocytes form the squamous epithelium. Type 2 pneumocytes secrete surfactant, a phospholipid-rich film that reduces surface tension and prevents collapse at end expiration. Alveolar macrophages patrol for debris. Capillary networks interlace alveolar walls. The air-blood barrier is only micrometers thick, consisting of alveolar epithelium, fused basal lamina, and capillary endothelium. Diffusion depends on surface area, thickness, and partial pressure gradients. Blood supply is dual. Pulmonary arteries carry deoxygenated blood from the right ventricle to capillaries around alveoli. Pulmonary veins return oxygenated blood to the left atrium. Bronchial arteries from thoracic aorta supply lung tissue and bronchi. Bronchial veins drain partly to pulmonary veins and partly to systemic veins. This dual system ensures the lung itself is nourished while also serving as the site of gas exchange. Lymphatics drain along bronchi and vessels. Superficial plexus beneath visceral pleura, deep plexus in bronchovascular sheaths. Flow converges at bronchopulmonary hilar nodes, then tracheobronchial, paratracheal, and into bronchomediastinal trunks. Because lymph flows along predictable channels, spread of disease follows anatomical maps. Hilar enlargement may be the first visible sign on imaging. Nerves come from the pulmonary plexuses, formed by vagus parasympathetic fibers. Parasympathetics constrict bronchi, increase glandular secretion. Sympathetics dilate bronchi, reduce secretion. Sensory fibers carry reflex and pain signals. Irritation triggers cough or bronchoconstriction. Severe acute shortness of breath with wheeze, chest pain, or hypoxia are red flags needing immediate care. The anatomy explains pathways but does not replace assessment. Clinical patterns follow anatomy. Aspiration more often involves the right lower lobe bronchopulmonary segments, particularly posterior basal because of vertical right main bronchus. Segmental pneumonia produces localized opacity on imaging. Tumors at the lung apex. Pankos tumors can invade brachial plexus and sympathetic chain, producing arm weakness and Horner syndrome. Pulmonary embolism, clot lodged in pulmonary artery, produces sudden chest pain, breathlessness, and hypoxia. It reflects obstruction of perfusion, not airway. Chronic interstitial disease thickens alveolar walls, impairing diffusion. Imaging reflects structures. Chest radiographs show lobar outlines and fissure displacement. CT maps bronchi and vessels, segmental distribution and nodules. CT pulmonary angiography demonstrates emboli. Bronchoscopy follows airway branching to segmental bronchi. Ultrasound detects pleural effusions and recesses, yet the tree image is sufficient, a trunk splitting into branches, each ending in clusters of leaves where air and blood meet. A vignette links detail to lived experience. A person aspirates a small object while laughing, soon develops cough and one-sided wheeze. Bronchoscopy reveals it lodged in the right main bronchus, explained by its wider, steeper course. Removal restores airflow. Sudden unexplained shortness of breath, chest pain, coughing blood, or new asymmetry of chest expansion always require prompt professional attention. A short reflection: when you view the lung as a branching tree within sliding pleura with countless tiny leaves for exchange, each breath becomes less effort and more rhythm. Now follow the path downstream, from alveoli to gut, where food, water, and secretions are digested and absorbed through a tube that folds, bends, and expands, assisted by liver, gallbladder, and pancreas. You follow a hollow tube from mouth to anus, a corridor where walls change form and function along the way. Food and drink pass through chambers that crush, churn, and dissolve. Secretions from liver, gallbladder, and pancreas enter through ducts, mesenteries, tether, and root vessels. The digestive system is a continuous canal with regional specializations. The oral cavity is the entrance. Lips mark its anterior boundary, cheeks form lateral walls, palate forms the roof, hard palate anterior, soft palate posterior with uvula hanging. The floor holds tongue, whose intrinsic muscles alter shape and extrinsic muscles reposition it, all supplied by hypoglossal nerve except palatoglossus vagus. Papillae on dorsal tongue host taste buds. Posterior third is lingual tonsil. Teeth, incisors, canines, premolars, molars cut and grind. Salivary glands parotid via Singeton's duct. Submandibular via Wharton's duct. Sublingual via many ducts. Secrete saliva with amylase and mucins. Oropharynx connects posteriorly. Swallowing begins voluntarily but continues reflexively. The pharynx guides bolus. The nasopharynx connects to nasal cavities via choanae and to middle ear via auditory tubes. The oropharynx lies behind oral cavity. The laryngopharynx leads to esophagus and larynx. The epiglottis deflects during swallowing, closing laryngeal inlet. Muscular walls contract in sequence, superior, middle, inferior constrictors, propelling bolus downward under vagus control. The esophagus descends from pharynx to stomach, about 25 centimeters, posterior to trachea and left atrium. It has cervical, thoracic, and abdominal parts. Constrictions occur at cricoid, C6, aortic arch, left main bronchus, and diaphragm, T10. Wall layers include mucosa, submucosa, muscularis, skeletal upper third, mixed middle, smooth lower, and adventitia. Lower esophageal sphincter prevents reflux. Dysfunction produces regurgitation. The stomach lies in the left upper abdomen between esophagus and duodenum. Regions: cardia at entry, fundus superiorly, body, pyloric antrum, pylorus with sphincter to duodenum. Greater and lesser curvatures give attachment to omentum. Greater omentum hangs like an apron, lesser omentum connects to liver. Rugae allow expansion. Wall has 3 muscle layers, longitudinal, circular, oblique, mixing contents into chyme. Gastric glands secrete acid, pepsinogen, and intrinsic factor. Pyloric sphincter meters emptying. The small intestine continues digestion and absorbs. Duodenum is C-shaped around head of pancreas, divided into 4 parts. Its second part receives bile duct and main pancreatic duct at the major duodenal papilla, controlled by sphincter of Oddi. An accessory duct may open proximally. Duodenum is retroperitoneal except first 2 centimeters. Jejunum and ileum extend intraperitoneally for several meters, suspended by mesentery. Jejunum has thicker walls, larger plicae circulares, long vasa recta, less fat and mesentery. Ileum has thinner walls, fewer folds, more fat, shorter vasa recta, Peyer's patches, lymphoid aggregates. The ileocecal valve regulates entry into cecum. The large intestine absorbs water and electrolytes, compacts feces from cecum. The appendix hangs, a narrow blind tube with lymphoid tissue. Ascending colon rises to hepatic flexure, transverse colon crosses to splenic flexure, descending colon runs down, sigmoid colon curves to rectum. Features include taenia coli, longitudinal muscle bands, haustra, sacculations, and appendices, epiploca. Rectum stores feces, anal canal ends at anus with internal, involuntary, and external voluntary sphincters. The pectinate line divides upper mucosal from lower skin-like zones with differing vessels, nerves, and lymphatics. The liver, largest gland, lies in right upper abdomen under diaphragm. Surfaces, diaphragmatic and visceral. Lobes, right, left, caudate, quadrate. Porta hepatis transmits portal triad, portal vein 75% blood supply, hepatic artery 25%, and bile ducts. Hepatic veins drain to inferior vena cava. Lobules are hexagonal units with central vein, radiating plates of hepatocytes, portal triads at corners. Functions include metabolism, detoxification, bile secretion, and storage. The gallbladder lies on visceral surface, storing and concentrating bile. It empties via cystic duct into common bile duct, which joins pancreatic duct. The pancreas lies retroperitoneal across posterior abdomen, with head in duodenum's curve, body crossing aorta, tail near spleen. It has exocrine auxini secreting digestive enzymes, delivered via ducts. Endocrine islets secrete insulin, glucagon, somatostatin. Main duct joins bile duct at hepatopancreatic ampulla. Accessory duct may open separately. Mesenteries and peritoneum support organs. The peritoneum is a serous membrane, parietal lining wall, visceral covering organs. Folds form mesenteries carrying vessels and nerves. Mesentery proper, jejunum, ileum, transverse mesocolon, sigmoid mesocolon. Greater omentum drapes from stomach, rich in fat and lymphatics, playing immune and protective roles. Lesser omentum links stomach and liver, retroperitoneal organs. Duodenum except first part, pancreas except tail. Ascending and descending colon lie behind peritoneum. Blood supply reflects embryology. Foregut, esophagus to mid-duodenum, liver, pancreas, spleen. From celiac trunk, left gastric, splenic, common hepatic. Midgut, mid-duodenum to proximal 2/3 of transverse colon. From superior mesenteric artery with jejunal, ileal, ileocolic, right colic, middle colic branches. Arcades and vasa recta distribute. Hindgut, distal third of transverse colon to rectum. From inferior mesenteric artery, left colic, sigmoid, superior rectal. Venous return through portal system to liver. Anastomoses exist between celiac and SMA, SMA and IMA, IMA and systemic rectal. Nerves follow vessels. Parasympathetic innervation, vagus for foregut and midgut, pelvic splanchnic nerves, S2, S4 for hindgut. Sympathetics from thoracic and lumbar splanchnic nerves, synapse in prevertebral ganglia. Enteric plexuses, myenteric and submucosal, coordinate motility and secretion. Sensation, visceral afferents follow sympathetics, producing diffuse pain referred to dermatomes. Parietal peritoneum pain is sharp and localized via somatic nerves. Clinical patterns mirror anatomy. Reflux occurs when lower esophageal sphincter weakens. Peptic ulcer erodes gastric or duodenal mucosa. Gallstones form in gallbladder, may lodge in cystic or common bile duct, causing biliary colic or jaundice. Appendicitis begins with vague periumbilical pain, midgut afferents, shifting to right lower quadrant when parietal peritoneum inflames. Bowel obstruction produces colicky pain, distension, vomiting. Gastrointestinal bleeding varies. Bright red per rectum, melena, hematemesis. Red flags, severe abdominal pain with rigidity. Vomiting blood, black stools, jaundice, sudden weight loss require urgent professional care. Imaging displays these regions. Radiographs show air fluid levels. Ultrasound depicts gallstones and liver. CT reveals obstruction and masses, MRI and MRCP outline biliary and pancreatic ducts, endoscopy visualizes mucosa and allows biopsy. Yet the core model remains a muscular tube with chambers, valves, and ducts, suspended by folds and supplied along embryological lines. A vignette illustrates a young adult develops right lower quadrant pain after vague central discomfort, with fever and tenderness. Appendicitis fits the migration and location of pain by segmental nerve supply. Severe generalized tenderness, guarding, and instability suggest peritonitis, an urgent condition. Reflection. Thinking of the gut as a long corridor with changing rooms, crusher, mixer, absorber, compactor, turns a complex system into an understandable journey. Next, trace the urinary system, kidneys filtering blood, ureters as muscular tubes, bladder as a reservoir, and urethra as outlet, all retroperitoneal corridors guiding fluid balance. You turn to two retroperitoneal looms that clean the internal river and shape its chemistry. Each kidney filters plasma, retrieves what you need, and sends the rest away through a muscular tube, the ureter to a low-pressure reservoir, the bladder that empties through the urethra. Their positions against the back wall keep paths short to great vessels and protect them behind viscera. The kidneys lie on the posterior abdominal wall, behind peritoneum, in perirenal fat enclosed by renal fascia, often called Gerotis fascia, with perirenal fat outside. The right kidney usually sits slightly lower than the left because of the liver. Posteriorly, both relate to diaphragm, psoas major, quadratus lumborum, and transversus abdominis aponeurosis. Subcostal, iliohypogastric, and ilioinguinal nerves cross the posterior surface. Anterior relations vary. The right touches liver, second part of duodenum, and hepatic flexure. The left touches stomach, spleen, pancreas, body tail, jejunum, and splenic flexure. At the hilum, the classic anterior to posterior order is vein, artery, pelvis, VAP, a memory that predicts where compression or variation will matter. Inside, cortex forms an outer cap and columns that dive between medullary pyramids. Medulla contains those pyramids, each apex papilla projecting into a minor calyx. Minor calyx merge into major calyx, then into the funnel-shaped renal pelvis that narrows to become the ureter. A nephron, the functional unit, begins with a glomerulus, a tuft of capillaries inside Bowman's capsule, filtrate, then traverses proximal tubule, loop of Henle, distal tubule, and collecting duct. Cortical nephrons have shorter loops, juxtamedullary nephrons have long loops that extend deep into medulla alongside vasa recta, enabling concentration by countercurrent multiplication. Water and solute handling is precise. You filter a large volume through fenestrated glomerular capillaries, then reclaim or secrete selectively across tubular epithelium under hormonal and local control. You do not need numbers to see the choreography, you need the map of where things happen. At the vascular pole of each glomerulus sits the juxtaglomerular apparatus, macula densa cells, in the distal tubule sense luminal content near the glomerulus, juxtaglomerular granular cells in the afferent arteriole release, renin in response to signals. Renin initiates a hormonal cascade that adjusts vascular tone and sodium handling system-wide. Erythropoietin, produced by interstitial fibroblast-like cells in the cortex, modulates red blood cell production. Kidneys also handle acid base by secreting hydrogen ions and reclaiming bicarbonate, and they activate vitamin D. These endocrine roles remind you that filtration sits inside a broader homeostatic net, coordinated with endocrine and cardiovascular systems. Blood supply is segmental. Each renal artery arises laterally from the abdominal aorta, and often divides before the hilum into segmental arteries that supply distinct renal territories with limited collateral overlap, an end artery pattern relevant to resection and infarct maps. Segmental branches give interlobar arteries that run between pyramids, arcuate arteries that arch along the corticomedullary junction, and cortical radiate interlobar arteries that feed afferent arterioles. Venous return mirrors but converges to renal veins. The left renal vein crosses anterior to the aorta, beneath the superior mesenteric artery. Compression here can raise left renal venous pressure, a nutcracker configuration, sometimes associated with left flank discomfort or a new left-sided varicocele that does not decompress when lying down. Accessory renal arteries are common and typically enter at the poles. Recognizing them explains variant ischemic patterns and hydronephrosis when a lower pole vessel crosses and indents the proximal ureter. The ureter is a narrow muscular tube about the width of a pencil that conducts urine by peristalsis. It descends on psoas major, crosses the pelvic brim near the bifurcation of common iliac vessels, and courses to the bladder. There are 3 physiologic narrowings where stones commonly lodge: the ureteropelvic junction, UPJ, the crossing over the iliac vessels at the pelvic brim, and the ureterovesical junction, UVJ, where it obliquely tunnels through the bladder wall. In the pelvis, relations diverge by sex. In females, the ureter passes beneath the uterine artery lateral to the cervix, water under the bridge before entering the bladder. In males, it passes under the ductus deferens near the bladder base. Segmental vascular supply arrives from adjacent sources: renal, gonadal, common iliac, internal iliac, so devascularization risk rises with extensive mobilization. The bladder, a hollow muscular reservoir, sits behind the pubic bones. Its wall is detrusor smooth muscle arranged in interlacing bundles that contract as a syncytium. The internal base forms a smooth triangle, the trigone between the 2 ureteric orifices, and the internal urethral orifice. Here, mucosa is more adherent, and the intramural ureteric tunnels run obliquely so that detrusor contraction compresses them and helps prevent reflux. Above, mucosa forms rugae that allow expansion. Peritoneum drapes superiorly. In males, the bladder lies anterior to rectum. In females, it lies anterior to uterus and vagina. A full bladder rises into the abdomen, palpable, and changes ultrasonic windows for pelvic imaging. The urethra conducts urine out. In males, it passes from the bladder neck through the prostate. Prostatic urethra, the deep perineal membrane and external urethral sphincter, membranous urethra, and the penis, spongy urethra. Bends and surrounding structures. Mean instrumentation follows gentle curves. Trauma can disrupt the membranous segment with pelvic fractures, risking extravasation into deep perineal spaces. In females, the urethra is short and straight, opening in the vestibule anterior to the vagina. Its brevity and proximity to the perineum contribute to increased susceptibility to ascending infection compared with males. Continence relies on coordinated closure of the internal smooth muscle at the bladder neck and the striated external urethral sphincter, rhabdosphincter, embedded in the deep perineal pouch, aided by pelvic floor support. Innervation coordinates store in void phases. Sympathetic fibers, primarily via hypogastric plexus, facilitate storage by relaxing detrusor and contracting the internal urethral smooth muscle. Parasympathetic fibers, pelvic splanchnic nerves, S2, S4, promote voiding by contracting detrusor and relaxing the internal outlet. Somatic fibers in the pudendal nerve, S2, S4, control the external sphincter and provide perineal sensation. Afferent signals from stretch receptors in the bladder wall ascend to centers that decide when social and situational context allows voiding. Descending pathways coordinate the switch. Disruption along any channel changes the pattern, urgency, retention, or incontinence depending on the level and nature of the interruption. Clinical patterns follow paths and narrowings. A person with a small calculus at the UVJ typically reports colicky flank pain that migrates antereinferiorly toward the groin, sometimes radiating to the scrotum or labia along ilioinguinal and genitofemoral nerve territories. Nausea and microscopic hematuria are common. Pain can hitch at the UVJ and recur near the pelvic brim as the stone traverses the constrictions. Fever with flank pain and chills raises concern for infection ascending to the kidney, pyelonephritis, and warrants prompt professional evaluation. Severe pain with inability to pass urine, visible blood in urine, new swelling or bruising after back or abdominal trauma, or sudden anuria are likewise urgent signals. Another vignette ties vasculature to sign, a new onset, persistent left-sided varicocele in an adult, especially if it does not decompress when supine, points you upstream to the left renal vein's course. Mass effect or venous compression can impede outflow. Gross hematuria, unintentional weight loss, or a palpable flank mass require timely assessment. Anatomy explains how venous routes and retroperitoneal space hide processes until they are sizable. Imaging translates corridors into pictures. Ultrasound demonstrates hydronephrosis, dilated calyces, and pelvis, and assesses bladder volume. Doppler evaluates renal artery velocities. Non-contrast CT sensitively detects calculi and localizes them to UPJ, pelvic brim, or UVJ. CT urography outlines collecting systems and ureters. MRI characterizes masses without ionizing radiation. Avoiding cystourethrogram can reveal vesicoureteral reflux by tracking contrast from bladder into ureters during voiding. Nuclear renography estimates split renal function and drainage, yet the mental model stays simple: cortical filter, medullary concentrator, funnel to a peristaltic tube, reservoir with an oblique inlet and guarded outlet, and a short final conduit tuned by autonomic and somatic signals. A short reflection settles when you imagine the urinary tract as a set of narrow corridors with specific gates and valves. Symptoms arrange themselves along the route rather than feeling random. Those pelvic corridors run beside reproductive organs and share vessels, fascia, and spaces. Next, you will walk the female tract, uterus, ovaries, and tubes, with their blood flow and lymphatic drainage mapped to the same landmarks as the ureters that pass quietly beneath. You step into a quiet courtyard with covered walkways and seasonal gardens. At the center stands a muscular hall, the uterus flanked by two orchards, the ovaries linked by slender galleries, the uterine tubes. Arches of peritoneum hang above as the broad ligament, and hidden conduits deliver blood and carry lymph away. The plan is symmetrical, the roots precise. The uterus is a hollow, thick-walled organ of smooth muscle called myometrium. Its upper dome is the fundus, below it lies the body. The narrowed lower segment is the cervix, which projects into the upper vagina and forms shallow recesses called fornices, anterior, posterior, lateral. The inner lining is endometrium, a mucosa that cycles in composition. The outer covering is perimetrium, a serosal layer continuous with peritoneum. In most adults, the uterus tilts forward, anteverted, relative to the vagina, and bends forward antiflexed at the internal offices. Variation is normal, and position can change with bladder or rectal filling and with life stages. Peritoneal reflections create named pouches and mesenteries. The broad ligament is a double layer of peritoneum draped from the lateral uterus to the pelvic walls. Within it, regional names locate structures: mesometrium along the uterine body, mesosalpinx supporting the uterine tube, and mesovarium tethering the ovary's anterior border. Posteriorly, peritoneum dips between uterus and rectum to form the rectouterine pouch, pouch of Douglas, the deepest peritoneal recess in the pelvis when upright. Anteriorly, a shallower vesicouterine pouch lies between uterus and bladder. These spaces matter because fluid, physiologic or pathologic, collects along gravity and peritoneal slopes. The uterine tube, also called fallopian tube, is a muscular conduit with 4 regions. The intramural segment traverses the uterine wall. The isthmus is a narrow, straight portion. The ampulla is wider and tortuous, the most common site of fertilization. The infundibulum ends in finger-like fimbria, close to the ovary's surface. Tubal mucosa is ciliated and secretory. Smooth muscle layers propel gametes and early embryos by coordinated peristalsis and ciliary action. Because the peritoneal cavity communicates indirectly with the outside world through the tube's abdominal ostium, infection can ascend from lower genital tract to peritoneal surfaces. Pain with fever and cervical motion tenderness needs timely professional assessment. The ovaries are paired gonads with an outer cortex containing follicles at various stages and an inner medulla with vessels and stromal tissue. They rest in a shallow depression, ovarian fossa, on the lateral pelvic wall, bounded by external iliac vessels above and ureter posteriorly. 2 ligaments define their attachments. The ovarian ligament connects ovary to the uterine horn, a fibromuscular remnant of gubernacular tissue, and the suspensory ligament of the ovary, infundibulopelvic ligament, carries ovarian vessels from the posterior abdominal wall to the ovary. Rotation of the ovary and its mesentery can twist this suspensory pedicle. Sudden unilateral pelvic pain with nausea and adnexal tenderness raises concern for torsion and warrants prompt evaluation because blood flow tracks through that narrow stalk. Support for the central hall blends muscle and fascia. The pelvic floor, levator ani and coccygeus, forms a muscular diaphragm beneath the uterus and vagina. Condensations of endopelvic fascia act as fibrous guy wires. The transverse cervical cardinal ligaments extend from cervix and upper vagina to the lateral pelvic wall and carry the uterine artery and veins. Uterosacral ligaments pass posteriorly to sacrum. Pubocervical bands pass anteriorly. These fascial sheets and the vaginal attachments resist downward displacement when intra-abdominal pressure rises. After childbirth or with chronic pressure, supports can stretch. A sensation of pelvic heaviness, a visible bulge at the introitus, or urinary or bowel symptoms should prompt professional assessment to map which supports have lengthened. Blood supply follows two main arcs with rich anastomoses. The uterine artery usually arises from the internal iliac artery's anterior division. It courses medially within the cardinal ligament toward the cervix, then ascends along the uterine margin, giving spiral branches into the myometrium and anastomosing with ovarian branches near the fundus. As it approaches the cervix, it crosses superior to the ureter. Water ureter under the bridge, uterine artery, a relation that guides safe dissection and explains patterns of ureteral injury in pelvic operations. The ovarian artery arises directly from the abdominal aorta, inferior to the renal arteries, travels in the suspensory ligament to the ovary, and gives tubal branches. It joins the uterine network near the horn. The vaginal artery, often from the uterine or internal iliac, supplies the vagina and lower cervix. Venous plexuses around uterus and vagina drain to internal iliac veins. The ovarian veins form a pampiniform plexus that coalesces into a single vein, draining on the right to the inferior vena cava and on the left to the left renal vein, an asymmetry that also appears in the testicular veins you will see next. Lymphatic drainage predicts where disease spreads and where immune surveillance concentrates. Ovarian lymph follows the ovarian vessels to para-aortic lumbar nodes, high in the abdomen. The uterine fundus also has a channel along the ovarian route. Some lymph from the fundus and the upper body follows the round ligament of the uterus, a fibromuscular cord running through the inguinal canal to the labia majora, to superficial inguinal nodes. Most drainage from the uterine body travels to external iliac nodes. The cervix drains to internal iliac and sacral nodes. The upper vagina drains like the cervix. The lower vagina and vulva drain to inguinal nodes. This pattern explains why enlarged inguinal nodes can in specific contexts relate to uterine fundus pathology, and why ovarian processes may present with para-aortic nodal enlargement rather than pelvic nodes alone. Innervation coordinates sensation and motor tone. Sympathetic fibers reach the uterus and tubes via hypogastric plexuses. Parasympathetic fibers arise from pelvic splanchnic nerves S2, S4. Pain from the fundus and body of the uterus often follows sympathetic pathways to T12 to L2 dermatomes, periumbilical to suprapubic, whereas pain from the cervix and upper vagina often follows parasympathetic pathways to S2, S4, sacral. These routes explain why cramping sensations can be perceived midline and referred to back or thighs. Autonomic balance also modulates vascular tone and glandular secretion, though hormonal signaling is the principal conductor of cyclical change. Endocrine rhythms shape the courtyard across weeks. Follicles in the ovarian cortex develop in cohorts. Typically, one dominant follicle progresses to ovulation, releasing an oocyte from the ovarian surface, which fimbriae of the tube sweep toward the lumen. The remnant transforms into a corpus luteum that secretes hormones to support early uterine receptivity. If implantation does not occur, hormonal support recedes, and the functional layer of endometrium sheds through the cervix and vagina. If implantation occurs, signals sustain the corpus luteum until placental endocrine activity matures. You need not memorize numbers to appreciate the flow. Orchard prepares seed, gallery receives, hall prepares surface. If unoccupied, the hall resets. Relations inform examination and imaging. The bladder lies anterior to the uterus. A full bladder tips the uterus. The rectum lies posterior. The posterior fornix abuts the rectoarm pouch, a window where intraperitoneal fluid can settle. Transvaginal ultrasound profiles. The uterus and adnexa with high resolution. Doppler assessment of ovarian flow complements suspicion for torsion. Hysterosalpingography outlines the uterine cavity and tubal patency with contrast. MRI clarifies junctional zones and deep infiltrating processes. Imaging reads best when the mental map hall, galleries, orchards, drapes, drains is already in place. Clinical patterns follow corridors and supports. a pregnancy that implants in the ampulla enlarges a thin-walled tube. Pain and bleeding in early pregnancy with shoulder tip pain or faintness are urgent signs for immediate professional care, because the peritoneal recesses and rich blood supply can fill silently. Fever with pelvic pain and discharge suggests ascending infection. Severe pain after exertion with adnexal tenderness suggests torsion. Heavy bleeding after long intervals of amenorrhea or any postmenopausal bleeding deserves timely evaluation. Sudden severe lower abdominal pain, persistent dizziness or fainting, foul-smelling discharge with fever, new unilateral swelling of a leg or inability to pass urine are additional red flags. Anatomy tells you where risk concentrates, not how to manage it at home. A brief vignette ties routes to findings. A person presents with intermenstrual spotting and deep pelvic pain that worsens with intercourse. Examination localizes tenderness near the uterosacral ligaments. Imaging shows nodular thickening along the posterior uterus and ovaries adherent to the lateral wall. The peritoneal drapes and adjacent nerves explain why lesions on posterior folds and within the pouch of Douglas can refer pain to the back and make movement painful. The same map predicts where lymph nodes might enlarge and how organs can tether when inflamed. A quiet thought lingers. When you see this region as a courtyard with seasonal orchards and covered walkways, you replace complexity with a plan: walls, roots, drains, and gentle cycles. Across the courtyard, another design solves a different task, producing and delivering gametes through a long conduit that loops over the bladder and passes through a gland at the base. How do the testes, ducts, and prostate organize space, blood flow, and drainage in the male pelvis? You step into a parallel courtyard, this one built for continuous production and long delivery. Two paired organs. The testes hang outside the abdominal cavity in a suspended sac, linked by cords that carry vessels and ducts. Their output travels through a winding duct, joins secretions from accessory glands, and exits via a long urethral channel that passes through the prostate and penis. The scrotum is a pouch of skin and dartos fascia containing the testes, epididymides, and distal spermatic cords. Its skin is thin with sebaceous glands and sparse hair. Dartos muscle in its fascia wrinkles the skin to regulate surface area and heat exchange. Each testes is covered by tunica vaginalis, a double peritoneal layer, visceral and parietal, derived from processus vaginalis descent, with a potential space between. Within lies tunica albuginea, a dense fibrous capsule sending septa inward to form lobules. Inside each lobule, seminiferous tubules produce sperm. These coiled tubes contain Sertoli cells that support spermatogenesis and form a blood-testis barrier between tubules. Leydig cells secrete testosterone under luteinizing hormone stimulation. Tubules converge to retestis and mediastinum testis, then to efferent ductules that enter the head of the epididymis. The epididymis is a long, coiled duct on the posterior testis. It has head, body, tail, sperm mature, and acquire motility here. The tail continues as the duct is fast to efferese a thick-walled muscular tube ascending in the spermatic cord. The cord passes through the inguinal canal formed by deep and superficial rings, alongside vessels, lymphatics, and nerves. In the cord lie testicular artery, pampiniform plexus of veins, lymphatics to para-aortic nodes, autonomic fibers, and the cremasteric muscle, an extension of internal oblique. Countercurrent exchange in pampiniform plexus helps cool arterial blood, optimizing spermatogenesis. The ductus deferens ascends, passes over external iliac vessels, loops over ureter, water under the bridge, and descends posterior to bladder. It expands as ampulla before joining ductus seminal vesicle to form ejaculatory duct, which pierces prostate and opens into prostatic urethra at seminal colliculus. Seminal vesicles are paired glands posterior to bladder, lateral to ductus, anterior to rectum. They secrete fructose-rich fluid, contributing most of ejaculate volume. The prostate is a walnut-sized gland, encircling prostatic urethra, inferior to bladder, anterior to rectum. It has base, apex, and lobes, anterior, fibromuscular, central, peripheral, transitional. Histology reveals tubulo-alveolar glands and fibromuscular stroma. Prostatic secretions add enzymes and zinc to semen. The prostatic venous plexus communicates with internal vertebral venous plexus, a route for metastatic spread. Inferiorly, the bulbourethral Copper's glands in deep perineal pouch secrete mucus into proximal spongy urethra. The penis is composed of 3 erectile columns, paired corpora cavernosa dorsally and a corpus spongiosum ventrally, enclosing urethra. Tunica albuginea surrounds corpora. Buck's fascia encloses all 3. Glans is the expanded distal corpus spongiosum. Prepuce covers it in uncircumcised individuals. Arterial supply arises from internal pudendal artery, branches dorsal artery, deep artery to corpora cavernosa, bulbourethral artery. Venous drainage passes through deep dorsal vein to prostatic plexus. Innervation includes dorsal nerve, pudendal, somatic sensory, cavernous nerves, parasympathetic from pelvic plexus, mediating erection, and sympathetic fibers, mediating emission and detumescence. Blood supply of testes arises from testicular arteries off the abdominal aorta near renal arteries descending retroperitoneally, crossing ureter and external iliac, and entering cord. Venous drainage forms pampiniform plexus coalescing into testicular veins. Right drains to inferior vena cava, left to left renal vein, explaining asymmetry in varicocele more common on left. Lymph drains to para-aortic nodes not inguinal despite scrotal location. Reflexes illustrate pathways. Stroking inner thigh stimulates ilioinguinal and femoral branch of genifemoral nerves, contracting cremaster via genital branch of genifemoral nerve. Testis elevates. Clinical absence may suggest cord or lumbar root lesion. Clinical correlations follow the map. Testicular torsion twists a spermatic cord, obstructing venous return and then arterial supply. Acute severe scrotal pain with swelling, high-riding testis, absent cremasteric reflex is an emergency needing urgent professional evaluation. Hydrocele arises when tunica vaginalis accumulates fluid, hematocele when blood collects, varicocele when pampiniform veins dilate, often left-sided, producing a bag of worms feel that worsens standing. Epididymitis produces scrotal pain, often with urinary symptoms. Any new scrotal mass, persistent pain, or testicular asymmetry deserves timely care. Prostate enlargement, benign or malignant, can obstruct bladder outlet, producing hesitancy, weak stream, incomplete emptying, frequency, or nocturia. Hematuria, bone pain, or weight loss are red flags for professional evaluation. Rectal examination can palpate posterior prostate through anterior rectal wall. Imaging mirrors anatomy. Ultrasound evaluates testes and scrotal masses. Doppler assesses flow and torsion. MRI and CT characterize pelvic organs. Transrectal ultrasound visualizes prostate. Angiography outlines penile vessels. Duplex ultrasound assesses erectile hemodynamics. Yet the simple model suffices. Orchards in a sac, cords as conduits, reservoirs as glands, and a long central channel passing through a gatehouse gland and erectile columns. A vignette ties detail to signs. An adolescent develops sudden severe left scrotal pain. Examination shows a high transverse testis without cremasteric response. Anatomy explains, torsion twists, cord structures, compromising venous return first, then arterial inflow. Immediate surgical evaluation is critical. Delay risks loss. Reflection. When you picture orchards linked to conduits with side reservoirs and one guarded channel, the layout seems deliberate, less tangled than it first appears. Next, trace the central control system, the brain, brainstem, cerebellum, and spinal cord with their blood supply, where all previous systems converge in command. You lift your view into the cranial vault, where a folded mantle of cortex, a compact trunk of brainstem, and a rounded cerebellum coordinate thought, sensation, and movement. Below, the spinal cord continues pathways through vertebral canals. All are nourished by an arterial ring at the skull base and drained by venous sinuses under dural folds. The brain weighs little relative to the body, yet consumes disproportionate energy. Enclosed by 3 meninges, dura mater, arachnoid mater, pia mater. The dura has periosteal and meningeal layers. Separations form venous sinuses, superior sagittal, straight, transverse, sigmoid. Falx cerebri partitions hemispheres. Tentorium cerebelli separates cerebrum from cerebellum. The arachnoid covers subarachnoid space filled with cerebrospinal fluid, CSF from choroid plexuses of ventricles. CSF circulates through lateral ventricles, third ventricle via interventricular foramina, cerebral aqueduct to fourth ventricle, then into subarachnoid space via median and lateral apertures, cushioning brain and spinal cord. Absorption occurs through arachnoid villi into venous sinuses. The cerebrum dominates. Two hemispheres are linked by corpus callosum. Each has lobes: frontal motor, planning; parietal, somatosensory, spatial; temporal, auditory, memory; occipital, vision; plus insula deep within lateral sulcus. Sulci and gyri increase surface area. Primary motor cortex in precentral gyrus sends corticospinal tract fibers. Primary somatosensory cortex in postcentral gyrus maps body sensation. Broca area in inferior frontal gyrus organizes speech production. Wernicke area in superior temporal gyrus interprets language. Association areas integrate across domains. Basal ganglia, caudate, putamen, globus pallidus regulate movement initiation and tone. Limbic structures, hippocampus, amygdala, cingulate gyrus regulate memory and emotion. The diencephalon sits centrally. Thalamus is a relay station for sensory input except olfaction. Hypothalamus coordinates autonomic and endocrine functions, controlling pituitary. Epithalamus contains pineal gland. The brainstem connects to cord and houses cranial nerve nuclei. Midbrain contains cerebral peduncles, superior and inferior colliculi. Pons contains transverse fibers linking cerebellum. Medulla contains pyramids where corticospinal tracts decussate. Nuclei for vital centers, respiration, cardiovascular. Cranial nerves 3 tech emerge here. The cerebellum posterior has two hemispheres and vermis with deep nuclei, dentate, emboliform, globose, fastigial. It coordinates motor activity, posture, balance. Damage produces ataxia, dysmetria, and tension tremor. Its input comes via cerebellar peduncles, inferior from spinal cord and medulla, middle from pons, superior to midbrain. The spinal cord extends from medulla to about L1, L2, then tapers into conus medullaris and cauda equina. It has cervical and lumbosacral enlargements for limb innervation. Segments give paired spinal nerves, 31 pairs total. Gray matter forms H-shape, dorsal horns sensory, ventral horns motor, lateral horns autonomic and thoracic. White matter contains ascending spinothalamic, dorsal columns spinocerebellar, and descending tracts, corticospinal, rubrospinal, vestibulospinal. Reflex arcs operate locally. Blood supply to central nervous system relies on arterial circles. Internal carotid arteries enter skull. Give ophthalmic, posterior communicating, anterior cerebral, middle cerebral arteries. Vertebral arteries ascend through transverse foramina, enter via foramen magnum, join as basilar artery, then divide into posterior cerebral arteries. Together they form the circle of Willis. Anterior cerebral arteries joined by anterior communicating, posterior communicating, linking posterior cerebrals with internal carotids. Collateral capacity varies. Aneurysms often occur at branch points, sometimes presenting as sudden severe headache. Venous drainage flows to dural sinuses. Superior sagittal drains along falx transverse and sigmoid to internal jugular. Deep veins drain into great cerebral vein of Galen to straight sinus. Spinal veins form plexuses in epidural space, connecting with vertebral venous system. Clinical correlations reflect anatomy. Stroke results from arterial occlusion or hemorrhage. Focal neurological deficit, weakness, speech disturbance, vision loss, facial droop. Onset within minutes requires emergency care. Subarachnoid hemorrhage from aneurysm rupture presents as sudden worst headache. Epidural hematoma arises from middle meningeal artery tear, often after temporal bone fracture. Lucid interval followed by decline is classic. Subdural hematoma arises from bridging vein rupture. Gradual decline may ensue. Spinal cord compression produces weakness, sensory change, sphincter disturbance. Rapid progression requires urgent evaluation. Imaging depicts structures. CT quickly detects hemorrhage and large infarcts. MRI shows white and gray matter, demyelination and ischemia. MR angiography depicts vessels. CT angiography shows aneurysms. Lumbar puncture samples CSF but requires exclusion of raised intracranial pressure first. A vignette. An older adult develops sudden right arm weakness and expressive aphasia. Examination localizes to left frontal cortex, supplied by left middle cerebral artery. Anatomy explains why vascular territory determines symptom pattern. Reflection. When you picture brain as a folded mantle above a trunk and a small rear coordinator, all bathed in clear fluid and linked by vessels. Symptoms fall into maps rather than mysteries. Next, trace the peripheral nervous system, plexuses of cervical, brachial, lumbar, sacral origin, where nerves braid and redistribute to limbs, carrying sensory fields and motor patterns. You step into a braided river where streams merge, split, and rejoin, so that flow can be rerouted without losing direction. This is the peripheral nervous system's plexus plan. Frontline somatic fibers, motor to muscle, sensory from skin and joints, braid from adjacent spinal levels into named nerves, then unbraid into territories called dermatomes, skin fields of a single spinal level, and myotomes, principal muscle actions of a level. The braid gives resilience. The maps give clinical precision. A plexus is a network where ventral rami from neighboring spinal nerves intermix before redistributing. The dorsal rami do not join plexuses. They supply the deep back and midline skin segmentally. 4 major somatic plexuses organize limbs and diaphragm, cervical, brachial, lumbar, and sacral. Alongside, autonomic fibers travel with them but arise from separate chains and ganglia. Here you focus on the somatic pattern that lets a single injury weaken a specific motion and numb a specific stripe while sparing others. The cervical plexus, C1-C4, forms within the neck's prevertebral fascia on scalenes. Sensory branches emerge at the posterior border of the sternocleidomastoid, near its midpoint, and radiate like spokes. Lesser occipital, posterolateral scalp, great auricular, ear and parotid region, transverse cervical, anterior neck, and supraclavicular, shoulder and upper chest. Motor fibers loop as ansa cervicalis, C1-C3, to infrahyoid strap muscles that stabilize the hyoid for swallowing and speech. A single long mixed nerve, the phrenic, C3-C5, descends on the anterior scalene into the thorax to supply diaphragm, C3-4-5, keep the diaphragm alive. Irritation of diaphragmatic pleura or peritoneum can refer pain to the shoulder via this nerve, explaining why subdiaphragmatic processes sometimes produce shoulder tip discomfort. The brachial plexus C5-T1 is the upper limb's main braid. You can memorize its layout as roots, trunks, divisions, cords, branches, but it reads easier as a map anchored to landmarks. Roots, ventral rami of C5-T1 emerge between the anterior and middle scalenes. C5 with C6 forms the upper trunk, C7 continues as middle trunk, C8 with T1 forms the lower trunk. Each trunk splits into anterior and posterior divisions behind the clavicle. Anterior divisions serve flexor compartments, posterior serve extensors. Divisions regroup around the axillary artery as cords named by position, lateral, posterior, medial. From cords arise terminal branches, musculocutaneous lateral cord, anterior arm flexors, lateral forearm skin, axillary posterior cord, deltoid/teres minor, lateral shoulder skin, radial posterior cord, all arm forearm extensors, posterior lateral limb skin, median lateral and medial cords, most forearm flexors and then precision, lateral palmar digits, ulnar medial cord, FCU, ulnar FDP, most intrinsic hand ulnar digits. Supraclavicular branches leave earlier. Dorsal scapular C5 to rhomboids and levator. Long thoracic C5-C7 to serratus anterior. Injury causes medial border winging, suprascapular C5-C6 to supra and infraspinatus, nerve to subclavius C5-C6. Infraclavicular branches shape the axillary walls. Lateral and medial pectoral to pectorals, upper and lower subscapular and thoracodorsal to subscapularis teres major latissimus, medial cutaneous nerves of arm and forearm for skin. Corridors matter, roots traverse the interscalene triangle, cords crowd behind the pectoralis minor, the bundle and subclavian vessels pass under the clavicle and first rib. Compression at the thoracic outlet, cervical rib, scalene hypertrophy, costoclavicular narrowing often affects lower trunk fibers, ulnar side paresthesias and hand intrinsic fatigue with vascular signs if the subclavian is involved. Patterns clarify injury levels. Traction to the neck and shoulder can injure the upper trunk. C5-C6, shoulder abduction and external rotation weaken, elbow flexion weakens, the arm assumes a waiter's tip posture. Traction on an abducted arm can injure the lower trunk. C8-T1, Intrinsic hand weakness and ulnar sensory loss dominate. Involvement of T1 sympathetic chain may add ptosis and meiosis on that side. A midhumeral compression of the radial nerve produces wrist and finger drop with dorsal hand numbness. A lesion at the spiral groove spares triceps because branches arise proximally. Red flags: rapidly progressive weakness, new numbness with neck pain, severe trauma, fever, or systemic symptoms warrant prompt professional evaluation. Braids hide critical roots that should not be guessed at home. The lumbar plexus L1-L4 forms within psoas major, its branches appearing predictably at the muscle's margins. L1 gives iliohypogastric and ilioinguinal nerves to lower abdominal wall and groin skin. L1-L2 gives genitofemoral, which emerges on psoas and splits to genital, cremaster, and scrotal labial skin, and femoral branches. L2-L3 forms the lateral femoral cutaneous nerve, which passes under or through the inguinal ligament near the anterior superior iliac spine to supply lateral thigh skin. Entrapment here produces burning dysesthesia, neuralgia, paresthetica. The largest motor branch, the femoral nerve, L2-L4, emerges lateral to psoas, passes beneath the inguinal ligament into the femoral triangle, powers quadriceps and sartorius, and provides the saphenous cutaneous branch to the medial leg. Medially, the obturator nerve, L2-L4, passes through the obturator canal to adductors and medial thigh skin. Irritation along the canal can produce exercise-related medial thigh or knee pain without joint pathology. A thick cord, the lumbosacral trunk L4-L5, descends to join the sacral plexus, an important bridge that brings lumbar strength to the lower plexus. The sacral plexus L4 lies on the anterior surface of piriformis and issues the limb's largest mixed nerve, the sciatic, composed of tibial L4-S3 and common fibular L4-S2. The tibial division continues through the popliteal fossa and posterior leg to the ankle, then into medial and lateral plantar nerves. It powers plantar flexors and intrinsic foot muscles. The common fibular division wraps around the fibular neck, vulnerable at this subcutaneous point, then splits into superficial fibular lateral compartment everters, dorsum of foot sensation, superior gluteal nerve, L4-S1, exits above piriformis to gluteus medius minimus and tensor fasciae lati. Its injury produces a Trendelenburg gait. Inferior gluteal, L5-S2, powers gluteus maximus for powerful extension. Posterior femoral cutaneous supplies expansive posterior thigh and perineal skin. Pudendal S2-S4 leaves and re-enters the pelvis to supply perineum and external sphincters. Dermatomes wrap the trunk and horizontal bands, T4 nipple line, T10 umbilicus, and flow down the limbs in spirals that reflect embryologic rotation. Upper limb, C5 lateral arm, C6 thumb, C7 middle finger, C8 little finger, T1 medial forearm. Lower limb, L1-L2 anterior proximal thigh, L3 over the knee, L4 medial leg and medial malleolus, L5 dorsum of foot and great toe, S1 lateral foot, S2 posterior thigh, S3-S5 concentric rings around perineum saddle area. Myotomes pair with simple bedside actions, C5 shoulder abduction, C6 elbow flexion, wrist extension, C7 elbow extension, C8 finger flexion, T1 finger abduction, L2 hip flexion, L3 knee extension, L4 ankle dorsiflexion, L5 great toe extension, hip abduction, S1 ankle plantar flexion, eversion, S2 knee flexion, S3-S4 pelvic floor. Reflex arcs sample these levels: biceps C5 C6, brachioradialis C6, triceps C7, patellar L3 L4, Achilles S1. Patterns matter because they separate a root lesion, dermatomal stripe and myotomal action, from a named nerve lesion, territory of that nerve, often spanning parts of multiple roots. Entrapment sites align with fixed tunnels and sharp turns. At the inguinal ligament near the anterior superior iliac spine, the lateral femoral cutaneous nerve can be compressed by belts or prolonged hip flexion. Purely sensory symptoms along the lateral thigh follow. In the pelvis or psoas compartment, hematoma can compress the femoral nerve, knee extension weakens, the patellar reflex fades, and anterior thigh sensation dulls. The obturator nerve can be stretched or entrapped in the obturator canal. Adduction weakens and medial thigh pain appears. Around the fibular neck, external pressure or prolonged posture can compromise the common fibular nerve. Foot drop and first web space numbness follow. Acute back pain with leg pain that follows a dermatome and accompanies new weakness suggests a root process rather than a distal entrapment. Sudden saddle numbness, new bladder or bowel dysfunction, rapidly progressive bilateral leg weakness, or severe trauma are urgent reasons to seek immediate professional care. These signs point to cauda equina or major cord plexus compromise rather than a single tunnel. A brief vignette matches braid to symptom. A traveler falls asleep in a cramped seat with a tight belt over the front hip. Upon waking, burning numbness blankets the outer thigh, but strength is normal and the knee reflex intact. The lateral femoral cutaneous nerve, purely sensory, passing under the inguinal ligament near the anterior superior iliac spine, fits the map. Symptoms localized to a single cutaneous branch, neuralgia paresthetica rather than to L2, L3 myotomes or femoral nerve. In contrast, foot drop with toe drag after squatting and pressure at the fibular head points to the common fibular nerve. Foot drop with back pain and great toe extensor weakness, but preserved aversion redirects you to an L5 root pattern. The braid lets you separate upstream from downstream reliably. Imaging and electrodiagnostics can confirm what maps suggest. MRI defines root compression and plexus masses. Ultrasound visualizes superficial nerves at tunnels. Nerve conduction studies and electromyography sample conduction along segments and denervation within muscles to localize lesions to root plexus or named nerve. Yet the braided river image remains primary. Tributaries roots join, split around sandbars, divisions, cords, and reform channels, terminal branches that irrigate fields, dermatomes, and drive mill wheels, myotomes. A brief thought settles when you see limbs wired by braids that reroute strength and sensation. Uncertainty softens, patterns become paths you can follow. Across these braids lie two quieter networks with wide influence, small endocrine glands that broadcast chemical instructions into blood, and lymphatic channels that drain tissues and train immunity. How do those subtle streams shape function and defense everywhere? You shift attention from large cords and trunks to scattered outposts that secrete molecules or channel lymph. These are the body's chemical broadcasters and immune drains. Small endocrine glands release hormones into blood, instructing distant targets. Lymphatic vessels return interstitial fluid and house immune cells. Their geography is precise. Each gland and node has a landmark, each channel a predictable course. The pituitary gland sits in sella turcica, suspended by infundibulum beneath hypothalamus. Anterior lobe, adenohypophysis, secretes trophic hormones under hypothalamic releasing factors delivered via hypophyseal portal system. Posterior lobe, neurohypophysis, stores and releases oxytocin and vasopressin produced in hypothalamic nuclei. This compact gland integrates nervous and endocrine commands, influencing growth, metabolism, reproduction, fluid balance. Lesions may enlarge sella and compress optic chiasm, causing bitemporal hemianopia, loss of peripheral vision fields, an anatomic consequence of chiasm position just above. The thyroid gland, an anterior neck below thyroid cartilage, has two lobes connected by isthmus across trachea. Pyramidal lobe may ascend from isthmus. Its follicles secrete thyroxine T4 and triiodothyronine T3. Regulating metabolic rate, parafollicular C cells secrete calcitonin. Blood comes from superior thyroid arteries, external carotid, and inferior thyroid arteries, thyrocervical trunk of subclavian. Sometimes a thyroidea ascends from brachiocephalic trunk. Venous drainage goes to internal jugular and brachiocephalic veins. Lymph drains to prelaryngeal, pretracheal, paratracheal, and deep cervical nodes. Parathyroid glands, typically 4, lie on posterior thyroid lobes. Their chief cells secrete parathyroid hormone regulating calcium and phosphate balance. Removal or injury risks, hypocalcemia with tetany. Anatomy explains surgical caution. The adrenal suprarenal glands cap the kidneys. Each has cortex zona glomerulosa fasciculata reticularis, producing mineralocorticoids, glucocorticoids, and androgens, and medulla producing catecholamines under sympathetic stimulation. Blood supply is rich, superior suprarenal, from inferior phrenic, middle from aorta, inferior from renal. Venous outflow is singular, right drains to inferior vena cava, left to left renal vein, an asymmetry that matters in surgery and tumor spread. Other endocrine tissues include pancreas, islets of Langerhans, insulin, glucagon, gonads, testes, ovaries, pineal gland, melatonin, circadian rhythms. Diffuse neuroendocrine cells exist throughout mucosae. Together, these organs distribute signals, adjusting metabolism, reproduction, stress, growth. The lymphatic system begins with blind capillaries collecting interstitial fluid, merging into larger vessels with valves. Along vessels lie lymph nodes, ovoid filters containing cortex with follicles, B cells, paracortex, T cells, medulla with cords and sinuses. Afferent vessels enter convex surface, efferent vessels leave hilum. Within nodes, antigen presentation and lymphocyte activation occur. Major clusters of nodes are regional, cervical superficial, along external jugular, deep along internal jugular, drain head and neck, axillary nodes pectoral, subscapular, humeral, central, apical, drain upper limb, breast, thoracic wall, inguinal nodes, superficial, horizontal, vertical and deep, drain lower limb, perineum, lower abdominal wall. Pelvic nodes line iliac vessels, para-aortic nodes flank aorta. Lymphatic trunks converge into thoracic duct and right lymphatic duct. The thoracic duct begins at cisterna chyli L1 L2, ascends through aortic hiatus, shifts left at T5, and empties into left venous angle, junction of internal jugular and subclavian. It drains both lower limbs, abdomen, left thorax, left upper limb, and left head neck. The right lymphatic duct drains right thorax, right upper limb, and right head neck into right venous angle. Specialized structures include tonsils, pharyngeal/adenoids, palatine, lingual forming a ring around pharynx, spleen in left upper abdomen filtering blood and housing lymphoid tissue, thymus in anterior mediastinum training T lymphocytes in youth before involution. Clinical relevance flows from these maps. Enlargement of supraclavicular node on left, Virchow node, can indicate abdominal malignancy, spread via thoracic duct. Axillary node involvement is key in breast cancer staging. Inguinal nodes enlarge in infections of lower limb or perineum. Painful tender nodes often accompany infection. Hard non-tender nodes raise concern for malignancy. Red flags, rapidly enlarging node, hard fixed mass, systemic symptoms, fever, night sweats, weight loss require prompt professional care. Lymphatic obstruction produces lymphedema, often chronic and disfiguring. It may follow node dissection or parasitic infection. Thoracic duct injury and surgery can produce chylothorax, lymph leakage into pleural cavity. Endocrine crises, adrenal insufficiency with hypotension. Thyroid storm with tachycardia, hypocalcemia with muscle spasms, present with urgent systemic signs requiring emergency evaluation. Imaging shows these networks. Ultrasound assesses cervical nodes and thyroid. CT and MRI show nodal chains. PET highlights metabolic activity in nodes. Lymphoscintigraphy traces drainage. Nuclear scans show endocrine gland uptake. Yet the schematic is simple. Endocrine glands act as broadcasting towers. Lymph nodes are sentry posts along drainage streams. Thoracic duct is the main trunk. Side ducts cover what the trunk does not. A vignette illustrates a person presents with painless enlargement of lower cervical nodes and weight loss. Anatomy explains why lymph from thorax and abdomen channels through supraclavicular region. Disease there may reflect deeper origin. Professional evaluation is essential. Reflection. When you see glands as towers and nodes as way stations, the complexity of widespread influence resolves into a lattice of landmarks. Next, view anatomy through another lens. Radiographs, CT, ultrasound, where key landmarks anchor the map, and the entire body summary closes in quiet coherence. You turn the lights down and let pictures glow. Shadows on radiographs, slices on CT, echoes on ultrasound. Each modality views the same body through a different window. Landmarks are constant, only the illumination changes. When you learn the language of density, attenuation, and echogenicity, the map you carry becomes visible on screens. Start with the simplest window, radiography. X-rays display a hierarchy of densities. Air appears darkest. Fat slightly lighter. Soft tissue and fluid form a middle gray. Cortical bone and calcification are pale. Metal is brightest. Because radiographs flatten 3 dimensions into 2, you rely on alignment lines, silhouettes, and paired views. In the chest, a midline tracheal air column sits above a gentle carinal bifurcation. Smooth costophrenic angles outline the bases. Right hemodiaphragm rides a little higher than left. The right heart border lies against the right middle lobe. The left heart border abuts the linguala. When a lobe becomes opaque and the adjacent soft tissue silhouette disappears, the silhouette sign localizes pathology to the touching lobe, an outline lesson more than a diagnosis. Spine films respect arcs. In the lateral cervical view, 3 smooth curves, anterior vertebral line, posterior vertebral line, and spiniolaminar line should remain continuous. A step in any line hints at malalignment. In the lumbar view, vertebral heights and disc spaces taper gradually. A wedge or slip changes the rhythm. At the pelvis, a continuous Shenton line sweeps from pubis onto the femoral neck. Breaks imply displacement. Pelvic ring fractures rarely occur in isolation. A second disruption hides until you trace the ring deliberately. The shoulder favors 3 views because direction matters. On the anteroposterior view, the humeral head should center on the glenoid. An axillary or scapular Y view clarifies whether the head sits anterior or posterior to the socket. Anterior dislocation is common, posterior alignment loss is subtler, and often follows seizures or shock. Limited external rotation alerts you to check the axillary view before assuming reduction. At the wrist, smooth gavula arcs trace the proximal and distal carpal rows. An interrupted arc suggests carpal instability. Tenderness in the anatomical snuff box after a fall points to the scaphoid. Its proximal pole receives retrograde flow, so a faint fracture across the waist matters even when radiographs are initially inconclusive. In the ankle mortise view, the clear space around the talar dome should be even. Widening at the lateral or medial gutter implies ligament or syndesmotic injury. Subtle changes in a ring carry significance. Computed tomography gives you depth by acquiring cross-sectional slices and reconstructing them in multiple planes. CT separates overlapping structures. Windowing emphasizes different tissues. Bone windows sharpen cortices and trabeculi. Soft tissue windows clarify organs and vessels. Lung windows expose bronchi, interstitium, and pleura. In the thorax, you see segmental bronchi as round or tubular airways accompanied by arteries. The bronchovascular bundle you traced in anatomy. In the mediastinum, you recognize compartments by their neighbors. Anterior, near the sternum. Middle, around the heart and pericardium. Posterior, along the spine and esophagus. In the abdomen, contrast time to the portal venous phase makes parenchyma uniform and highlights masses against the predictable enhancement of liver, spleen, and kidneys. CT of the head quickly distinguishes dense acute blood from brain. Subdural collections hug the convexity. Epidural collections lens between skull and dura. Subarachnoid blood outlines sulci and cisterns. The map of Fasciae and foramina you learned explains why small collections compress specific cranial nerves or tracts. Magnetic resonance imaging refines soft tissues further. On fluid-sensitive sequences, hydrated discs in the spine gleam while cortical bone stays dark. A posterolateral protrusion indents the bright thecal sac. In joints, menisci and labrum appear as dark fibrocartilage against brighter joint fluid. Tears interrupt uniform signal and shape. In the brain, diffusion imaging highlights acute ischemia within minutes by restricted water motion. Vascular territories turn from abstractions to crisp patterns. Ultrasound trades penetration for portability and dynamic assessment. Fluid is an echoic black and conducts sound. Bone and calcification are bright and cast clean shadows. Soft tissue varies. In the abdomen, the liver serves as an acoustic window. The gallbladder sits tucked beneath its right lobe, thin-walled when fasting and echoic. Bright stones drop shadows. The right kidney nestles against the liver. The left sits under the spleen. Both show a darker cortex around a bright central sinus. The aorta lies left of midline, a round pulsatile tube that should compress less than the inferior vena cava on the right. In the pelvis, a full bladder becomes a black reservoir that improves views of uterus or prostate. In vessels, Doppler color and spectral traces translate flow into direction and waveform. Veins collapse with gentle probe pressure. Arteries do not, principles that guide recognition rather than procedures. At the bedside, focused ultrasound surveys dependent spaces for free fluid. The hepatorenal recess in the right upper quadrant, the splenorenal recess in the left, the pelvis behind bladder or uterus, and the pericardial space. Small volumes collect where gravity and peritoneal reflections invite them, the same spaces you mapped in peritoneum. New shortness of breath with chest pain, fainting, One-sided weakness, severe abdominal pain with guarding, or trauma with deformity are urgent reasons for professional evaluation. Images complement but never replace assessment. Vascular imaging echoes your arterial and venous trees. CT angiography outlines lumens and branch points. MR angiography avoids ionizing radiation for many beds. Duplex ultrasound measures velocities and compressibility in limbs. In the neck, a smooth carotid bifurcation should taper. Irregular plaques change luminal shape and flow. In the legs, deep veins should coapt under probe pressure. Failure suggests thrombus. A cold, pale, painful limb with weak pulses is a circulation emergency. A warm, swollen calf with tenderness and sudden chest pain is a different emergency. Anatomy names the corridor. Urgency sets the pace for care. A short vignette brings landmarks to life. A person with fever and cough has a chest film where the right heart border is lost, but the right diaphragm remains crisp. Localization points to the right middle lobe more than the lower lobe. Examine labs refine the cause. In another case, an ankle mortise view shows slight widening medially after a twist with inability to bear weight. Subtle separation of the ring suggests deeper ligamentous injury. In both, the picture follows the plan you already hold. Reflection drifts in lightly. Once you can label a few shadows and corridors, uncertainty softens, not because pictures give answers, but because their grammar matches the anatomy you now speak. Hold this composite image of seams, rings, hinges, tunnels, cords, and springs. Now let the edges soften as the whole design recedes into a single steady body at rest. Let your attention widen until details blur into a calm outline. The skull's vault, the gentle S-curve of the spine, the rib ring that rises and falls, the pelvis like a sturdy bowl, all of it nests together, each piece supporting another. Inside that architecture, soft tissues slide, fascia glides over muscle, pleura lets lungs whisper against the chest, synovium cushions small arcs at every joint. Vessels thread through these passages with patient rhythm. Nerves carry signals that come and go like quiet tides. Glands release a drop at a time into the river, and the river carries those messages everywhere. You do not need to hold every name. You can let form replace lists. A hinge here, a pulley there, a spring underfoot, a ring at the base that bears weight with a small tilt. You can feel that learning this map is not a race. It is a slow walk through rooms. You can revisit in any order. If a corridor is unclear, you already know the neighboring rooms. Follow a vessel, track a nerve, put your palm on a bone, and let the road appear. When a picture looks confusing, check your landmarks. Roofline, column, ring, bowl, and the shadows will fall into place. As you rest, imagine the whole as one quiet system. Air trading for blood in a tree of tiny leaves, blood looping out and back through elastic pipes, filters tending the chemistry, cords sending brief sparks, muscles shortening and lengthening with economical grace. Nothing is static, nothing is hurried. The body is busy and deeply peaceful at the same time. You can let that steady cooperation be the last thought that stays as the room grows still and the map folds itself neatly for later.